that I get to share some information about the language guide. But that was a huge, I saw the KT resource PowerPoint that was sent out last night from the conference, where the BC language guide is being used for the SFU mobilization, knowledge mobilization initiative.
Yes, yeah.
Which is just like huge. Like most people like dream of like having that uptake, because we just released it and now it's already being being used and being.
Yeah, well, I saw it and I thought it was so great. I flipped it over to both our communications people and I think the library picked it up as well. And so it also went to our knowledge mobilization people. It's fantastic. It is a great guide. So congratulations.
Yeah.
Thank you.
We had to go back and modify our agenda because of it, Harlan. We went through and made sure.
The Health Canada right now is trying to secure the funds because they would like to translate it into French.
Oh, fantastic. Yeah,
So
as they should. Yeah.
They're trying to figure that out. I have a neighbor who is a grad student at UBC's anthropology department, and through the ethics process that use marginalization and vulnerable, it looks like maybe their UBC anthropology is going to use R&D, Robin Duplicate, the framework of that language guide for their department. I don't know where that's going to go, but that's like kind of cool because anthropology has not been kind as public health.
No, I totally understand that.
Yeah.
I love the Robin duplicates. That's great. I love that. R&D Robin duplicate.
I think we should get started, if I may interrupt. Kat, shall I go ahead?
Yes.
Okay, thank you. So good morning, everyone. September 2, day 2 of the BC COVID-19 Research and Collaboration Symposium on Public Health, Populations, Health Services, and Impact, a fantastic effort at collaboration across many groups and institutions in British Columbia. I'm Peter Berman. I'm the director of the School of Population and Public Health at UBC and co-chair of this symposium with Tanya Bubla from SFU. So we'd like to open up this morning with some comments of welcome from President Joy Johnson at SFU, who's on the line. And President Johnson, I think, is only a couple of days in office. So we're very grateful that you were able to find the time to join us this morning. And she is also a professor in the Faculty of Health Sciences at SFU. So thank you, Professor Johnson, over to you.
Thank you very much, Peter. I'm absolutely thrilled to be here this morning. I want to begin by acknowledging that I am located at my home on the traditional unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh people. And I just want to begin by recognizing that. Peter, I want to thank you and Tanya for taking on this humongous task. I know it takes a lot of people to put something like this together, so also want to thank all of those working behind the scenes. I know there are many partners involved besides SFU and UBC School of Population Public Health, the Michael Smith Foundation, the BC Academic Health Science Network, UNBC, University of Victoria, and the BC Support Unit. So thanks to all of you. This is a critical time. Indeed, it is my second day as president of Simon Fraser University, and it is my first official welcome that I'm doing. And I couldn't be more pleased because you are my people. I am a health researcher myself. I am passionate about public health issues, particularly those related to the ways in which different social locations can affect health. And we are seeing during this global pandemic that indeed we have to be paying attention to different populations and their particular needs. I'm really very, very pleased as well that we are seeing so many participants from so many different walks of so many different disciplines participating. I understand there's 500 registered attendees, and we have participation from across all 6 health authorities. So that's absolutely amazing. I think we all recognize that none of us are going to solve these issues that are ahead of us alone, and collaboration is vital. These are complex issues that we're dealing with, and there are so many unanswered questions, everything from cell to society. And so to understand the impacts of the SARS-CoV-2 virus, to understand implications of this pandemic, it really requires a public health and health services perspective. We need to understand the impacts on our society as a whole and really develop interventions that will make a difference. As I've mentioned, this pandemic has also opened up a number of cracks and really exposed inequalities in our society. We know that the elderly, precarious workers, Indigenous communities, and women are just some of the groups who really are being differentially impacted, whose economic status and well-being are particularly at risk. And I know you're addressing this in your program, and I'm so pleased to see that. Gatherings like this are so important because they do help to align our efforts to really think about ways we might have collective impact. I really do believe in collaboration, and I'm so pleased to see so many examples in the research being presented of collaboration that's taking place already, but love to see that built upon over time. SFU is a community engaged research university, and we are committed to continuing to strengthen partnerships to really leverage our resources to address this pandemic and to really work with communities as well. And I know all of your institutions are doing that as well. So I commend you for that. But let's redouble our efforts. Let's continue this work because the road ahead, I think, is going to continue to be fairly difficult. There is a lot of great work being done across our institutions, from statistical modeling to international collaborations to developing new technologies. And I think, as I said, this work is vital, and indeed we need to continue to support it. So I really want to congratulate you on your program. I'm so thrilled about the interdisciplinary nature of the symposium, and really confident that the connections that you're making and building will really help us to move the agenda forward together. So we need to work to build capacity as we develop vaccines, share information, create connections, address public health policy, strengthen our programs. This will make us stronger and better prepared for the future. So I really want to wish you a productive day. I want to congratulate you once again on the work you're doing. I look forward to learning more from Tanya about the outcomes of this important symposium, and I wish you all the best. So thanks so very much.
Thank you very much, President Johnson, for those words of appreciation, motivation, inspiration, and please feel warmly invited to join us for as much as you can, given your busy schedule. And thank you again. So before we turn to the first session, I just want to review some of the housekeeping items we went through yesterday. Yesterday, I began by begging forgiveness for the limitations of technology. My sense is I didn't need to use up much of your stock of forgiveness, so please hold on to it for another day. I hope we won't need it, but we are performing a challenging task here in many sites and locations. I should have begun by noting that I speak to you from the traditional territories of the Abenaki peoples in the eastern part of North America. So just to say how broad our reach is in this event. And I'm appreciative of the opportunity to do that. The main sessions are being recorded and live streamed on the Faculty of Health Sciences YouTube channel. The link to the YouTube channel has changed for day 2, and Kat can probably post the new link on the chat for those who want to use it. And the recordings will be available through the Academic Health Sciences Network's YouTube channel after the event. Critical we stay on time. Chairs are doing the timekeeping for their sessions, and will be reminded. And as As noted, we will try to stick pretty strictly to the schedule, even though we're going to be 1 minute behind schedule for this opening session. Please do be muted. You should be muted automatically, but in case you are not, please mute your microphones so that we don't have disturbance coming from outside the session. A hashtag can be used if tweeting about the symposium, hashtag BC COVID research, and we can put that, Kat, please, on the chat again for people to see. All of the main sessions will be accessible through this Symposium Zoom meeting link that you've already logged onto, if you have. But the breakout sessions, which will alternate with the main Symposium sessions, each breakout room has its own Zoom meeting link. These are located at the bottom
Except for today.
Except for today. Sorry, Kat, go ahead.
Except for today. Sorry about that. We only have one breakout room and it will be continuing in this main session, but we will be stopping recording and live streaming for that breakout room.
Okay,
Thank you.
Great. Thank you, Kat. So there, I've already used up one unit of forgiveness. So good to keep up with the details. And we hope that the breakout session will be a great opportunity for discussion and it will not be recorded. So with those items, Kat, anything else that I have forgotten that I should mention? Okay, I think we're good. I'm turning over the microphone to Dr. Sterling Bryan.
Great, thank you very much. And it's so I'm Sterling Bryan. I'm the president of the BC Academic Health Science Network. And I'm actually at my workplace, despite the background might suggest otherwise, but I would like to acknowledge that my workplace is within the ancestral, traditional, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So I'm delighted to chair this session, and this is a session that's going to be on support platforms, and platforms that are designed to support high-quality health research on COVID-19. And the session is going to be describing the platforms that form part of the provincial research response to COVID. And the idea is that this session complements yesterday's opening session that Bev Holmes chaired, that described the key elements of the provincial response to COVID-19. So we have 5 speakers in this session. Terry Fleming, who is the Director of Research Ethics BC, which is one of the component parts of AHSN. Stephanie Cheer, who's the Project Manager for the Reach BC platform. Lindsay Hedden, who's the Assistant Scientific Director at BC AHSN and also faculty at Simon Fraser University. Kim McGrail, who is the Scientific Director of Pop Data BC and a Professor at the School of Population and Public Health at UBC. And Harlan Pruden, who we've met and discussed. So he'll be discussing his work, and he's a First Nations Cree scholar and an educator at BC CDC. So each talk is going to have 10 minutes of presentation, and I've indicated that I will be cutting people off after 10 minutes, so we're going to try and keep to the time. And given that the talks are on quite different topics, we're going to allow 1 or 2 questions to happen after each session, and then we will allow, then hopefully have some time for more general question and answer at the end of the session, and we'll be going through until 10:30 this morning. So just to say, BC AHSN has 3 operating units: the Research Ethics BC, as I've mentioned, Clinical Trials BC, and also the BC Support Unit. And the latter is seeking to ensure that we listen effectively in health research to the voices of those with lived experience, patients, and the public. And so what I would like to do in this session is particularly encourage questions from those with lived experience, patients, and the public. So what I'm going to ask is, if you are asking a question and your question comes from a lived experience perspective, either from a patient or public perspective, then if you put patient or public as the first word in the question, that'll help me to identify those questions, and I'll give I'll give prominence to those questions. So But please, that's what I'm encouraging in this session, is that we actually listen more effectively to the voices of patients and public on these topics. So that's my suggestion. So we're going to go through each, as I've said, we'll go through each speaker in turn. We will have 1 or 2 questions after each speaker, and then we'll have some general Q&A at the end. So without any further ado, I'm going to turn over to our first speaker, who is Terry Fleming. So I'm hoping that Terry is able to share her screen so that we can see her slides. So I would ask Terry to do that now, if you could. And we're a go. Great. So I'll hand over to Terry, who is the Director of Research Ethics BC. So over to you, Terry.
Thank you. Good morning, and thank you, Sterling, and the other organizers for asking me to be here today. I'm going to be providing some information on the rapid research ethics review process that was created for clinical COVID-19 studies. As this diagram shows, we have a large network of research ethics boards in the province that work with us at Research Ethics BC. We were originally formed as an initiative to find a harmonized or single review process for multi-jurisdictional studies. Since the harmonized processes were established in 2015, our network has grown to include 19 research ethics boards across the province. It was because of the relationships that we formed within this network that we were able to begin the population of the BC COVID-19 inventory of research that Lindsay will tell you a little bit about later. Very soon after the declaration of the public health emergency in BC, we started to hear from researchers, the ministry, Health Canada, funding agencies, and various other stakeholders that there was a need to quickly obtain ethical approval for studies so as not to delay the start of vital research. Clinical research, such as that being submitted to investigate the SARS-CoV-2 virus, develop new treatment options, and vaccine development, all require review by a clinical research ethics board. The institutions listed here were involved in the development and agreement of the rapid review process, as they would be the most affected institutions. The rapid review process expanded on the harmonized review already used by the clinical research ethics boards. One research ethics board, the Board of Record, conducts the review, and it is accepted by the other research ethics boards. This review takes place within 5 days of the receipt of the application. Research Ethics Board members were prepared to have meetings on very short notice and fully engage in a swift but thorough research ethics review. Health authority research ethics boards agreed to provide only local institutional comments within 24 hours. This is because even in this time of need, it was vital to ensure the autonomy of the research ethics boards, as this was at the very core of the harmonized review models agreed to this date. Once reviewed, the researcher receives a single document that includes input from all health authorities where the study could be conducted. When the researcher responds to the review and all provisos are considered satisfactory to the Research Ethics Board, they will receive a certificate of ethical approval for all regional health authorities. The other key element is the agreement to one privacy consultation, if required. And the process should eliminate the possibility of duplicate privacy reviews by health authorities as part of the ethical review process. Some interpretations by institutions of the BC privacy legislation overlaps with the review already conducted by Research Ethics under the Tri-Council Policy Statement, Ethical Conduct of Research Involving Humans, or TCPS2 for short. The research ethics boards will not always have a privacy specialist embedded in the review process, but when they do, it should eliminate the need for a separate review. We all agreed that it was necessary to reduce duplication, and so one privacy consult would suffice for a study. 2 weeks later, we expanded the model that you see that I've described here to allow for a provincial level ethical review for incoming clinical trials that are intended to be provincial in scope. The results of putting this process in place are going to be more fully reviewed by the clinical research ethics community, but some early numbers are that the rapid review process was applied to 74 multi-jurisdictional studies on COVID-19. But this represents only a small number of the over 254 COVID-19 research studies that have received ethical review since March, both as single institutional studies and multi-jurisdictional studies. We know that there are more that have not yet been included in the inventory and are collecting more information weekly. So what did we learn? I have heard the term unintended consequences a lot over the last few weeks, and we have identified a couple as well for our rapid review process. While it was well and good that our research ethics community agreed to a rapid review and single privacy consult for COVID-19 clinical studies, this did not allow enough time for the other institutional-based review or approval processes to fully engage. During a normal ethics review process, there may be a couple of weeks between the time the study is received and the research ethics review or meeting which is held, which allows for the other institutions usually involved to, like the health authorities, to notify the operational reviewers within their institutions. Their review processes can include things like information privacy and security consultation, legal, contracts, data management, clinical leadership, etc. And normally this would launch a concurrent process. As we saw with a couple of very important studies in the province, differences in interpretation of privacy legislation and how it is applied, as well as legal contracts, cause delays in the launch of studies in some institutions. In my opinion, this is unacceptable in the best of times. But I think that the quote, "It will never be perfect, make it work," applies here, and we have an obligation to resolve the problem of multiple separate review processes for research studies once and for all. I'm happy to say that I'm working with some colleagues on some recommendations to this end, and they will be shared very soon. And that concludes my presentation. And I think I'm under 10 minutes. So I'm happy to take a couple questions if anybody has any.
Thank you very much, Terry. So please feel free to send me a private question if you would wish to do that, rather than sharing it openly on the chat, or share it openly on the chat. So please do that. I'm going to just say a huge thank you to Terry, her colleagues at Research Ethics BC, and her colleagues who work in research ethics across the province for getting us to this point. I think it's just a remarkable step forward for us to, as a province, have a single research ethics process that we've got for COVID. So I guess, like, as a starting point, I'll kick off the questions. I don't see any at the moment in the chat. The legacy for non-COVID research in BC, is it too early to hope that we might move in this direction for non-COVID research, Terry?
There's a couple of aspects to that. I think part of it would be the rapid part of the review. So the rapid part of having the review conducted within 5 working days, really difficult to commit to that for a legacy when you don't have the prioritization of certain types of research, as we did with COVID-19. All other research kind of stopped, and so COVID-19 was the priority. So there was that ability to do that within 5 working days. But when you're talking about, across the province, hundreds of new research studies every year, I think it might be a bit tough without more resources to commit to that 5-day rapid review. But with regards to the other aspects, and in particular, I think this would pertain to harmonization of other operational processes. I'm really hoping that we can drive that forward, that we've seen through this model that although it worked for research ethics, it opened up that gap and showed us very clearly the problem that we've all known for over 10 years was an existing problem and that we've needed to kind of tackle. And this is the time, this is the opportunity we have to do that.
And with you at the helm, I'm confident that we're going to make progress. Thank you, Terry. So we have a question that has patient. So just as a reminder, if you put patient or public at the beginning of your question, then I'll give it priority in this session. So thank you, Terry. This is a question from Lisa Ridgway. I love the "make it work" mantra. Can you tell us how patient partners were involved in research ethics boards and reviews during COVID-19?
So I wouldn't be able to speak on behalf of every board at this time. I know that every research ethics board has an obligation to have community members involved in the research ethics board. That is described in Tri-Council policy statement, and it's absolutely necessary. I also know that some boards specifically have patient partners as in a specific role on their research ethics board, but I wouldn't be able to speak to how they were involved in each of the individual research studies. I'm sorry, I can't provide that information, Lisa.
So I think that's something that we'll explore and get back to Lisa on. So we've got one other question, which I think we'll have as a final question, and then we'll move on to Stephanie. So this is a question that's how do we hold people accountable for decisions that unnecessarily delay rapid response research? Thank you, Terry.
That's a tough one, but I think that part of what we're trying to do with the recommendations that we're coming up with on our small but mighty working group is we're trying to aim the briefing that we're providing about possible and the recommendations we're providing at the right level. And so we're trying to aim this at the decision makers in the organizations to profile for them what is going on and what the issue is and how it could be resolved, and that they are, as decision makers, have that ability to do that. So I think that is one way that we're trying to hold them accountable is aiming this messaging at the decision makers at the highest level.
Great. Thank you very much, Terry. I just want to again just reiterate the thanks from us as a research community in the province for the work that you're doing to move research ethics forward in BC. Thank you very much. So we'll move to our next presentation. So this is going to be a presentation on the Reach BC platform that Stephanie Chia is going to present. Stephanie is the project manager for the Reach BC platform and has been working on this now for some time, and we're at the point where Reach is now launched. So it's a great opportunity for others to learn more about the platform. So over to you, Stephanie.
Thank you, Sterling. And thank you everyone for this opportunity to share about Reach BC. I'm really excited, especially for those who may not have heard about Reach BC yet. It's a platform that's been developed and just recently launched. Took several years. It was developed as a demonstration project of the BC Support Unit with Dr. Robert McMaster from Vancouver Coastal Health Research Institute leading it as principal investigator. So let's see if this works. Go to the next slide. What is Reach BC? It's a new online platform that connects British Columbians to health research opportunities that are either related to the health conditions that they have or what they're interested in. And as I mentioned, it was a demonstration project of the support unit. Over several years, it was developed with a provincial working group, and that included individuals from the health authorities, research institutes, universities, as well as patient partners sat on this provincial working group to help develop what Reach BC has become. We also conducted several stakeholder engagement sessions with different community groups across the province. So there were about, I think we had 5 consultations where we really were gathering requirements into what was needed to go into this platform. So I like to share this picture that I took at the BC Children's Hospital. This is a bulletin board in the hospital. I'm not sure if it's still up, but it was up a few years ago. It's a participate in our research board where researchers will post their studies that are looking for participants, and they're hoping that a patient or member of the public walks by and sees their poster and identifies themselves as like, oh, this might be interesting to me, and then they take the phone number. So this kind of represents what Reach BC was aiming to help support, both for researchers who are trying to find participants for their studies, but also for patients or members of the public who are interested in research, but they might not be at that hospital at that time when that poster is posted. So we've taken this idea and brought it online into Reach BC. So what ReachBC has is a provincial-wide directory of research projects that are actively looking for people to participate in their project. It's a publicly searchable directory. But not only in this directory, not only are there research studies like clinical trials, behavioral research studies, we also have patient partner research opportunities. So for any researchers who are conducting patient-oriented research and looking for patient partners, we also share those through ReachBC. And one of the key things that ReachBC is about is we created this software, or what we like to call like a matching engine, where we will automatically match people to those projects that might meet their interests. So when you come to ReachBC as a member of the public, you can sign up and you create a profile for yourself. And then we'll match you based on that profile to projects based on your age, sex, gender, where you're located, and the health research categories that you've selected. So really, we're giving it to the public, or a volunteer's choice, really. You'll get matched to all the projects that are available in the directory, and then you can review and choose which projects are interesting to you. And by clicking a button that says, I'm interested in this project, I want the researcher to contact me, we connect you to the research team. So it's each project you're giving basically permission for that researcher to contact you. So the ReachBC platform, we developed it with a lot of subject matter experts. Privacy was consulted. We take users' privacy very seriously, and we built it so that it's protected and secure. And so people can feel safe about the information that they're providing in ReachBC. We've also worked to be collaborative with a lot of organizations that overlap with what ReachBC does. So we've worked with the BC Support Unit, Clinical Trials BC, Research Ethics BC, all to ensure that what we've developed with ReachBC, our processes are streamlined with any existing processes out there for the research community. And right now, during the COVID-19 time, we've also worked with the BC Centre for Disease Control, as well as the COVID-19 Clinical Research Coordination Initiative to ensure that we're working with those COVID-19 processes. So the next couple of slides, I'm going to tell you about how ReachBC is supporting COVID-19 research. When we launched in April, it was a little bit earlier than what our original timeline was for ReachBC, but we realized it was an opportunity really to make ReachBC available to the public and researchers in order to hopefully expedite COVID-19 research. So right now we have a process with the Centre for Disease Control, CDC, where we're contacting all COVID diagnosed patients who survived. And that process involves the CDC sending an introductory letter to those patients and a follow-up phone call where the patient is asked, are you willing to be contacted about research into COVID-19? Yes or no? And then if they say yes, ReachBC will help send out an email with an activation link to create their ReachBC volunteer account. Once they're a ReachBC volunteer, as I mentioned, like the whole process is automatic. They get matched to the research projects. If they're interested, they get connected to the research team. And here's some early numbers from that COVID-19 process. This is a couple weeks old, so I don't have the most up-to-date numbers at this time yet, but about 1,800 patients were on that list to be contacted by the CDC. And of that 1,800, 801 were contacted so far. And then 609 of them said yes to be contacted about research. So about 76% said yes to be contacted about research. That's really great to know that these patients are interested in research. And that actually matches what a public opinion poll about the BC population determined, that about 70% of people are interested in participating in research. So of those who said yes, 561 of them have email addresses. And that's important for us as ReachBC because that's required in order to join ReachBC. We do know, of course, that now there's some people who are interested in research who don't have email and it may not join ReachBC because of that, or they're not comfortable joining ReachBC as an online platform. So we're happy to say that ReachBC is also involved in coordinating how those patients will be contacted about research, and they will hear about research as well. So we're trying to include everybody. So lastly, how researchers can recruit COVID patients for their projects. They can do it easily through ReachBC. First, you create a ReachBC researcher account, and that's for a principal investigator must do that, the PI, or as well as a study team member, like a research coordinator can do that. You submit your research study or patient partner research opportunity, which will be reviewed by the ReachBC office. And then you can connect with volunteers that match your project and who are interested in being contacted. So I hope that those of you who did not know about ReachBC see this as a great tool that you can use, either if you're patient or member of the public interested in research, you can go to ReachBC, search our directory, see what's out there. Or if you're a researcher looking for participants, we're hoping that this will help help your recruitment processes and be more efficient for you. I'd like to acknowledge all the input that went into the development of ReachBC, especially from the patient partners who were on our working group. And we had a patient advisory group as well for the testing of our site, the research institutes, health authorities, as well as all the organizations here and our funders and partners who were involved in launching ReachBC. And that's the end. I just want to say thank you again to all those who provided input into this. A lot of the people I think are on the call, on the conference today. So thank you again.
Great, thank you very much, Steph. And I just wanted, I know it's not been an easy road to get to this point, but I think we have something very special in ReachBC for the province. And I think it's a work in progress. And I don't think that, I mean, I'm sure that people, I mean, I've seen some very, very positive messages in the chat about its functionality. And the idea, I'm sure, is for it to improve as we go. But I would want us to all embrace ReachBC and to be using ReachBC as we move forward, so that it can be the go-to platform for us to connect patients and patient partners to research opportunities, and really just to enhance the quality of research that can happen and the efficiency of research in BC. So I think that's fabulous. So thank you very much for all of the work you've done on this. So just as a reminder, if you want to me to prioritize your question, and you are a patient or a member of the public, then just start the question with the word patient or public, and I'll do that. So a couple of questions have come in. So one question is about awareness amongst the public, and how are you, or how are we ensuring that everyone is aware of this and has the opportunity to respond and to sign up for Reach?
Yes, I actually forgot to mention that in the presentation. So when we launched in April, the main focus was to build up our ReachBC directory of projects. So the main focus of announcing ReachBC was for the research community to really populate the projects onto the directory. So now that we've had a few months and we have about 26 projects on there, 11 of them are COVID related. We're going to be this fall looking at some marketing activities, which it will include some advertising like social media campaigns and those types of things to really get the word out there. Another, I didn't get to talk to her yesterday, but another thing is really getting the Ministry of Health to support ReachBC and really promote it through, maybe a public update, or have Dr. Henry mention it would be our ideal goal. I'll be presenting at several conferences and meetings over the fall, and the support unit conference being one where we'll do a public kind of launch of ReachBC. So there's a number of activities we're planning.
I think the general, sort of just the promotion of this platform to the public, I think is going to be really, really important. So I think those who wish or can help and support that, then I guess they should be connecting with you directly.
Yes.
Because I think we do need to make sure that people know about this and know about it quickly. But also the research community. We need the research community to respond and to place opportunities on Reach, to use Reach. Because it only is going to be successful.
That will drive people to come to Reach, for sure.
So we had a question. Peter wants to know about, Peter Berman wants to know about Reach in terms of social and behavioral research. So is this a platform that can facilitate social
Behavioral research? Yeah, there's a number of behavioral research projects that were approved by the BREV, the Behavioral Research Ethics Board on ReachBC right now, a lot from the population health faculty. So these are surveys, online surveys that they're looking for participants to take the surveys, and some of them are related to COVID-19, some are related to other things like stress and mental health. So those are available.
Great, thanks very much. So does ReachBC have any social media we can share? I think the answer is yes.
Well, we could use the hashtag ReachBC. And we have like our partner organization, Vancouver Coastal Health Research Institute, has been sharing and posting, and I think that's getting reshared by a lot of other partner organizations. I don't have an account myself for ReachBC. That's actually taken the Twitter name. So we had to, and we don't have the bandwidth to manage a social media channel at this time, but we'll use the hashtag ReachBC, and hopefully as our partners share posts, that can be reshared across the channels.
I think we need to find a solution to your lack of bandwidth on the social media front at this point. So, and Victoria has suggested, in fact, that we promote ReachBC, that everyone who's part of the symposium should be sharing the information about ReachBC, so that
would be amazing and great.
Yeah, and it is going to be part of the support unit's annual conference this year, Putting Patients First, which is on October the 8th, and registration is now open. As an aside, if you wish to register for that conference. Good. I think we'll close at that point. So we'll come back if anyone has any further questions relating to Reach. We'll have that in the open Q&A later on. But again, a huge thank you for everything you're doing to get us to this point, Stephanie, and the team. I think it's a special resource for the province, and something that really should give us a strong advantage. So thank you very much. Okay, we'll move on now to our third presentation, and Lindsay Hedden is going to be presenting, and she's going to be sharing information around the research, the BC inventory of COVID-19 research. Lindsay, as I said, is the Assistant Scientific Director at BC HSN, and also faculty in the Faculty of Health Sciences at SFU. So thank you very much, Lindsay.
Thanks very much, Sterling. So I would like to start by sending a huge shout out to the fantastic team of staff that have been instrumental in putting this research inventory together. It has been an absolutely huge amount of trying work that was done off the side of several people's desks. So I would be entirely remiss by not acknowledging that right off the bat. So we've heard over the course of this conference that there really has been a rapid proliferation of research efforts focused around COVID-19, which is great, but it does lead to potential for duplicative work. There have been formal research registries developed, particularly in the areas of clinical trials, in order to reduce things like publication and reporting bias, to reduce unnecessary duplication, and to improve transparency. But these tend to be really narrowly focused on clinical trials, and we're not aware of any other resources that are more broadly focused for things like behavioral research, for example. Victoria Schuckel, in her comments yesterday, actually referred to the importance of coordination specifically in this area, just because of the sheer amount of work that's happening and a need to be strategic in terms of funding things that are not already funded. So collaboration is needed among both researchers and funders so that we're minimizing duplication of work and maximizing the number of projects that we can fund. So we had two linked objectives when we started work on this registry. The first was to create and maintain a living and public database of research projects that have some relation with the COVID-19 pandemic. And the second was to facilitate and support linkage between individuals and groups that are doing similar or related work, either from a content perspective or from a methodological perspective. So this work started primarily as an internal partnership with Research Ethics BC, and the big sort of dump of initial data that we were able to put into the database actually came from submissions to various ethics boards. The limitation to this approach is that we were really only able to catch projects that had progressed far enough that they were seeking ethics approval or that required ethics in the first place. So the second step we took was to pull information from funders of research that had been posted publicly, like the Michael Smith Foundation and CIHR, and enter information that way. Following that, we undertook a substantial outreach campaign where we've asked researchers to connect with us about projects that they're involved in, that are ongoing, but maybe hadn't reached the point where they were receiving ethics approval yet, or where they hadn't achieved funding. And so we've been filling in forms or having researchers enter the form manually to make sure that the database is as comprehensive as possible. And what you should see on the screen now is a screenshot of what the inventory looks like. And you can see the URL in the upper right-hand corner there. So when you come to the page, the first thing to point out is that if you scroll to the right, there's actually a substantial amount of information contained about each project. So we collect data on the lead investigators in BC and the investigative team, the lead and other organizations that are involved, the type of research, so whether it's biomedical, clinical, health services, population, public health policy, whether it's patient-oriented project, what type of funding they've received, whether it is specific to BC or part of a larger project, what geographic regions it covers, the study population, and lots of other relevant information. So make sure you do scroll all the way to the right so that you can see all of the bits and pieces that we've been able to collect about each project. At the bottom there, you're able to filter and sort based on each of the fields that are listed in blue. So for example, if you only wanted to take a look at projects that were being conducted across Canada, you can filter and sort by that. You can also change the number of projects that you see. The database is getting quite substantial, so it's easier sometimes if you're only showing a subset of the results. You can search for anything, an individual's name, a keyword. So the search is really robust, so it's really easy to find what you need to find. And lastly, you can export it, all of these into a variety of formats. So if you wanted to download it as an Excel file to do a bit of analysis yourself, you are absolutely able to do that. So as of Monday morning, we were actually up to 380 distinct research projects. I just checked before the session started this morning, and we were up to 385 of those 385 projects, which over the matter of like a few months is absolutely incredible. Of those, 49% cover population and public health areas, or 185 projects, and 22% or 83 cover health services and policy. 10% or 37 studies here are cross-cutting, meaning that they cover more than one of CIHR's 4 pillars. We also did some analysis of the types of questions that are being asked specifically within the health services and policy and population health areas. So among the health services studies, 39% are looking at healthcare service effects for specific patient populations. 37% have a focus on health workforce, 22% around health system capacity, 28% on responding to non-COVID health needs, and 13% on other or unknown. And of all of these projects, 30 of them, or 36%, identified that they were addressing more than one of these project areas. Similarly, for population and public health, you can see there's a huge spike there in terms of those projects that are looking at effects on specific patient populations. So it's just under 2/3 actually have that as a core focus. 19% are looking at the development of public health measures, 32% in terms of the effects of stay-at-home and physical distancing, 12% on general population health outcomes, and 5% other or unknown. And of all of these projects, 55 or 30% are addressing more than one of these research areas. So in terms of geography, 65% of the projects in our database are specific to BC, and 35% are part of a larger multi-provincial or multinational study. We did some work to look at the geographic distribution within the province. So to be clear, this does not represent the organization that is responsible for the particular research project. Instead, it's looking at the health authority geography within which data are being collected. So you can see there's a massive number in Vancouver Coastal Health. Around 80% of the studies are doing at least some data collection within the Vancouver area. 21% within Fraser, 10% in Interior, 14 in Island, 6 in Northern. And there were 16 studies, or approximately 4%, that are actually doing data collection across the entire province. So in terms of next steps, we are just started this process of being able to build a report that will summarize inventory content. And the emphasis of that report is really going to be on identifying gaps. So what research areas can we see are not being addressed within the large scope of research that's being done? What are the patient populations whose needs are not being addressed by research? What clinical contexts are not being addressed? And we're hopeful that that can be informative in terms of future calls for funding and just to support researchers to start work in areas that are not currently being addressed. We also have plans to map the research projects according to the newer Strategic Research Advisory Committee priorities, which we're hopeful are going to come out soon. And in hopes that, again, that makes the content of the inventory more useful for our ministry partners. And lastly, and I think probably most importantly, we're expanding to think about how we can link the content of this inventory to the actual results of research. So stay tuned for that. And I'd like to conclude with a plea, which is just that if your project isn't listed here, and if you've had a conversation with your research team and you've checked so you know it's not there, please write us and let us know. This tool really is only useful if it's as complete as possible. And at the moment, we do have to require, or we do have to sort of depend on active participation from researchers to collect that information. There is no comprehensive source that we can draw from. Similarly, if the status of your project has changed, please contact us. So what I mean by that is if you entered a study when you were applying for a CIHR COVID grant and you were unfortunately not successful and now that study is not going forward, please let us know. That's really important so we can make sure that the registry is accurate. And lastly, when you do start to produce results, be open to sharing them with us. When we do find a way of contacting you about that, we're not sure yet exactly what that's going to look like, whether it's going to be a link to publications, reports, or other things, but be open to sharing so that we are able to include that information. My contact details are there and the link to the inventory as well, and I'm happy to take any questions.
Great, thank you very much, Lindsay, and thank you for the team that's put this together. I know that it's being used in a very active way now, and I'm sort of excited at the prospect of us using it for that sort of like synthesis within particular areas to give an in-depth description of the work that is currently happening. It's interesting, like the N of 385. That's 385 research studies that are happening on COVID in BC is remarkable. Like that's a huge success story. It's also like something that we need to learn from around coordination and collaboration, I think. So I think there are two messages that I take from the N being 385 at this point. So just as a reminder, if anyone wants to if a patient or a member of the public, just put patient or public at the beginning of the question, and I'll prioritize that question. So Diane Finegood asks, what are the use cases for the registry, and how do you expect it to be used?
So I think there are two things that spring to mind right away. And the first is in terms of being able to support targeted funding going forward. So if we see that there is a large amount of research in one area, but there's a priority that's been identified by the Strategic Research Advisory Committee, for example, that isn't being covered, then that I think there's impetus there for funding agencies to be putting targeted funding such as RFPs to support research being done in those areas. The other thing I would say is, as somebody who's trying to be actively involved in COVID-related research, taking a look at the inventory to see if something that I'm interested in doing is already being covered by another team, and connecting with that team is another way that I have heard of people using it and that I have used it myself. So those are the two that I would say right off the bat.
Great, thank you very much, Lindsay. And I think, I mean, one of the areas that I think we'll use as a starting point is long-term care. So I think there's a lot of interest in what research is happening in long-term care around COVID at this point in BC. And BCHSN is working in the area of long-term care anyway. So I think we'll certainly have that as an initial area that we'll give some focus to. I just wanted to actually make reference additionally to the work on surveys. So there's also an inventory of COVID surveys, COVID-related surveys that are happening in BC. That's on the BCAHSN website. That's collated by the ministry and is shared through the BCAHSN website. So just out of interest, there are 118 COVID-related surveys happening in BC at the moment, and many of those are collecting data that can be shared. So and used in health research. So just to be aware of that. So Larry asks, are registry projects being directed to post on REACH?
Not that I'm aware of, but that's actually a really great idea. Thank you, Larry. I think what we could do is post something on our on the research inventory page. Oh, and Dan's just posted it in the chat there. So I guess when folks go to the URL there, we could include a link also to Reach BC, or put a mention on the inventory about Reach BC.
It would be great. We do have like individual researchers who find Reach BC themselves to post their own registry. Like we have one on emergency department registry that's going to be posted soon. But yeah, to just spread the word.
Great. Okay, thank you very much. And thanks Lindsay. And again, thanks very much to everyone who's contributed to supporting the development of this resource that I think is enormously helpful for us as we think about coordination of COVID research moving forward. Good, so let's move on. So our next presenter is Kim McGrail. Kim probably for this community needs no introductions, but I will give her an introduction anyway. So Kim is the Scientific Director of PopData BC and also a professor in the School of Population and Public Health at UBC. And Kim's going to be talking to us about PopData BC and the resources that are, or the support that's available for COVID research through PopData BC. Kim, over to you.
Great, thank you very much. I'll just get this shared. And now I have to get it started properly. Okay, so what I'm going to do is obviously a bit of a quick tour of the sorts of things that we're launching. Some of this was in plan anyway and has been sped along by COVID, which I think is a common theme for lots of people. So just to make sure that everybody has same understanding of PopData, we're a provincial resource, actually accessible to anybody in Canada, but we definitely focus on BC. We really want to support research on health services, but also determinants of health more generally, and well-being and development. We have partnerships with multiple data stewards, both in the province and elsewhere, national partners, for example. We are key partners for COVID-19 research, including with the health sector, with Ministry of Health and Health Authorities, but also with the broader government data innovation program, which I'll cover a little bit later. And PopData is essentially the front door for researcher access to these kinds of data. I just want to acknowledge that there's lots of partners that we have, and what we're doing with PopData is we really take this sort of broad strategic view of wanting to make sure that we're offering innovative practice to support researchers, that we're problem solving. So when people want to do things that aren't quite in the realm of the possible right now, we want to help make those things happen. And we really are effectively doing this through partnerships, which I think you can see from the wide variety of various partners and funders we've had. This is really fundamental to the way that we work. And I acknowledge particularly the AHSN and the BC support unit is PopData is a very active and happy partner in that grouping. See, our core kind of functions for PopData are providing data access, conducting data linkage, providing secure data storage and archiving, and we have a whole education and training arm, including a population health data analysis certificate program. Underpinning this, we have been quite active over the last few years in deliberation with the public around data, and particularly around how we best support researchers' desires for more data linkage and more innovative research, but in a way that's respectful of expectations and values of the public. So just very, very briefly on why we think pop data is is necessary. And you might have noticed that I framed the title for this talk as creating science infrastructure. And I think that that's a kind of a fundamental piece of what we're trying to do, is to help researchers not feel whenever they want to do a data-based project, a secondary database project, that they're not just spending their time pushing a rock up a hill. That for data stewards, we provide transparency and a service so that, that they don't have to use their own resources to do everything involved with supporting data access, although data stewards retain very important roles and responsibilities. And for the public, we want to make sure that there's transparency about what's happening with data that are collected through public means, but also that the public has the greatest benefit from what we can do with data. Because to this point, I would say that we leave a lot on the table. We're not using all of the data that are available to us to their greatest effect, which is not a critique of researchers. It's really much more of a comment that there's great things going on and so much more that we could be doing. So the current data resources that we have available for request, I'm not going to read through this in detail. All of this information is on our website. You can go and read about these things. What I really just want to highlight is that they're very broad. So we have healthcare and health services data, a range of data sets that are provided either through the Ministry of Health or health authorities. We also have population vital statistics information on early childhood and education, occupational data, demographics and life course data, including the BC Generations survey project, which includes biological samples, and then a fair bit of ecological data too, that describe the context, the social context or the environmental context in which people live. And then there's lots of service developments we're pushing forward. Again, this is very much in partnership with data providers and others. A couple of these on the top are things that we've really been able to accelerate with COVID-19. So one of these is the idea of a core product. And this is effectively a way to have a faster turnaround for data requests, as long as if you're a researcher and request a set of fields that are effectively pre-approved by data stewards, that they're potentially available for research, that it will mean quicker approval times and a positive effect on costs as well. Just to be clear, that the data component is only one requirement for researcher access. You still have to fulfill all the other requirements like ethics review and so on. But this is, I actually think that this is a fundamental step change in the way that we will have data access, and we will expand this beyond COVID-19 projects as soon as we can. Another piece that we've been able to make happen for COVID projects is access to open year data. And what I mean by that is we're not any longer restricted to only providing fiscal year files. So for example, if you were to make a request now for healthcare services data, and one of the files you wanted was PharmaNet with prescription information, we'd probably be able to provide data up at least through July of 2020. So it means that the research we're doing can be far more contemporaneous and responsive to current priorities, which clearly in the context of COVID is really important. We're working on programs of research. So with the intent that these are interconnected projects that would use a similar or the same data resource. So this will be more efficient for researchers and acknowledges that researchers might need data for a longer period of time. And we're always upgrading our secure research environment, which is essentially a private cloud. And we're adding some GPUs in to support machine learning. for researchers that wish to go in that direction. I also want to talk about a couple new opportunities that are coming. One I mentioned at the very beginning is this BC Data Innovation Program, which is the partnership with Pop Data and that part of government to make the non-health, well, plus health data available, as well as the health sector data. So this would be things like income and work data, justice, education, early childhood, and social supports. And these data are available for COVID-19 related research. And like I said, this is a really big step forward, and would be happy to provide more details if people need those. The other opportunity is we're part of a pan-Canadian health data research network called Health Data Research Network Canada. And so this network is funded by CIHR through the Strategy for Patient-Oriented Research and is aimed at supporting multi-jurisdictional studies. So if you're interested in doing things in BC plus Ontario or BC plus Ontario and Alberta, or whatever configuration you're interested in, there's services there that you can find out what data are available, and we will support the access process. So that's really the main things I wanted to provide. There is both the general information on Pop Data and the data access process online, and also a specific COVID-19 page, which you can find from any page on our website. So the website is there, and I will stop there for now. Thank you.
Thank you very much, Kim, and thank you for being perfectly on time. And actually, again, just to say, a huge thank you. I think the work that Kim and Pop Data have done in BC, and then obviously in partnership with Ministry and other organizations to get us into this place is we're a great place to be doing database research in BC, and that's largely because of the work that Kim's been leading at Pop Data. So thanks very much for that. A couple of questions have come in. I have to admit that my wife always tells me that I'm not great at multitasking, and I'm having to multitask now. So I'm trying to keep on top of all of the chat that's happening. There was a question from a patient partner that actually related to surveys, but I think it may be something that you could comment on, Kim. So the question was, if I complete a survey for one study, can my data be used for a different study? And would I be informed about that possibility? I know it's not directly relating to your talk, but I thought you might have a comment on that, Kim.
Yeah, it actually does relate, at least in the context of COVID-19, it relates to some other work that's been going on. For those who aren't aware, the Faculty of Medicine at UBC started a clinical research coordination initiative, which now is very much provincial in nature. And part of that really is a couple things. One is taking very much an open science approach to COVID-related research, understanding that we are blessed in this province to have relatively small number, although unfortunately growing number of people with COVID-19, and we can't overburden them with research. So it's really important to coordinate. And if multiple research projects are interested in similar or the same types of survey questions, then it's really much better to share them rather than to ask people to respond to pretty much the same thing more than one time. So this really depends on how consents are set up in the first place. And we're encouraging people to take a broad consent approach so that it will enable research to different projects to use the same survey data collection. So at least in the context of COVID, I think we're aiming in that direction. And yes, for sure, it would be a responsibility of research teams to inform patients of what studies they've been involved with.
Thanks, Kim. Another question is, it's more of a comment and then a question. It is remarkable that none of the healthcare professional associations are partners of Pop Data BC. And I hope that yesterday's Learning Health Systems presentation is a shift towards integrating frontline healthcare and health research. You would think that they are inseparable. Comments, question mark.
I mean, certainly, I think professional organizations and clinical providers are absolutely involved in the research that's supported by Pop Data. They have not to this point been directly involved in Pop Data itself, although I actually think one of the directions that we should be going is getting more into the health human resource work space. So understanding who actually is a provider, and thinking, particularly in COVID-19, I've been thinking about the effects on providers in the healthcare system of being in that frontline situation. So very, very interesting projects to link, for example, nursing registrations or physician registrations, and just to along with the long-term care pieces that Sterling already mentioned. So I agree that it's an interesting future area of development, and learning health system is the right frame for that, for sure.
I would agree strongly with that. So thank you very much, Kim. And yeah, thanks again for everything you're doing for placing BC in such a great place to do data-related health research. I'm going to move on. I know that there are other questions. We might come back to some of those questions in the general overview, but I just want to move to Harlan Pruden and give Harlan a fair share of the time to discuss his great work. And I have to say, I've been using it as well, the COVID-19 Inclusive Language Guide. So Harlan is a First Nations Cree. He works with and for the Two-Spirit community, locally, nationally, and internationally. He's an educator at the BC Centre for Disease Control and specifically for the Chi Mamuk program as part of BC CDC. And he's an Indigenous public health, which is the Indigenous public health program. Harlan is also the managing editor of the Two-Spirit Journal, which can be found at twospiritjournal.com. So thank you very much, Harlan, for the work you're doing and for agreeing to share it with us today. So over to you, Harlan.
Thank you so much. Tanse, no chachamte Harlan Pruden, e waka no mani e Motormouth Mabel, niha 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 ayakwe. Greetings, my relatives. I'm here to talk about, well, my government name is Harlan Pruden, but you can also call me Motormouth Mabel because I'm going to be talking very, very fast because I have a lot of information to share with you. What I'm going to be talking about is language is power, or the power of language, and focusing my conversation on the BCCDC COVID-19 Language Guide, Guides for Inclusive Language. And I'm honored to be here, and I wish to acknowledge that I am a visitor and a guest of the Coast Salish people, specifically the Squamish, Tsleil-Waututh, and Musqueam First Nations people. All right, a little bit of background of where did this language come from. So back in February, early February, I was redeployed and appointed to the BC CDC's COVID-19 Communications Working Group for the development of public-facing guidance. And you can see that on our website. And then in early March 2020, the NIAID, Anthony Fauci's organization, released their language guide, and I'm on a national advisory board in the US to help with the recruitment of Indigenous people, but also BIPOC people within clinical trials. And so they shared me an advanced copy, and I was like, wow, this is amazing. So I was using that guide to help with inclusifying the language around the public-facing documents. And then in late March, thanks to Michael Smith Foundation, Emily Rempel, Katie Fenn, and myself, were awarded as PIs a rapid survey to access of knowledge, attitudes, and behaviors around misinformation, personal protection, and public health measures for COVID-19 in BC. And also, the nasty V word was showing up on our website as one of the categories. And I'll talk a little bit more about that. Plus, some of the guidance that was coming around was using words like risk that is potentially stigmatizing, as the NIAID document was showing. So that kind of led me to like, we should come up with our own guide. So a little bit about the survey, because I think the survey really was some of the key impetus for the development of this guide. So the Michael Smith Foundation awarded us an award to proactively address the infodemic within BC related to COVID-19. The overall sample size was about 3,000, just over 3,000, and it included around 400 Chinese, 150 Indigenous, 140 South Asian, and Southeast Asian and about 837 South Asian British Columbians. There was also questions to address Two-Spirit as well as LGBTQI communities in a culturally safe and sensitive way. And the data was collected way back in April 14th to the 19th. Some of the the questions included demographics, knowledge, communication preference, as well as health and harming coping strategies or behaviors, as well as some measures on stigma and discrimination. I am not going to talk a lot. I'm only going to talk about 2 pieces of data that helped with the justification for this language guide. Now, when it comes to information, we asked the question of, when it comes to information about COVID, I actively look for information from people and groups, and it shouldn't come as a surprise that Dr. Henry showed really high with a 54% of people actively looking for information from Dr. Henry, which is great. But it shows that about 46% of people were not looking to Dr. Henry. And then there is also of the sample size, about 45% were looking to Justin Trudeau and looking federally for that information. Now, this is where most research stops with an aggregate of the larger data set. But if we take that same sample size and we break it down by race and ethnicity, we see a slightly different picture of that data. So of that 54% of folks that were looking to Dr. Henry, 58% were white, 46% Chinese, 45% South Asian, 47% Southeast Asian, and about only 38% Indigenous. And if we juxtapose that with looking at Justin Trudeau and that sample, is that 45% were white, 39% were Chinese, and you have this huge increase of South Asian, 59%, and another significant increase, Southeast Asian, 55%, and that 38%, Dr. Henry, for Indigenous people, 51, or about 1 in 2 of Indigenous people were looking to Justin Trudeau. And so we're seeing how the message is landing differently across different publics. And then we asked some questions around observed stigma and stigma behavior. And I wish I had more time to unpack this, and I'm sorry that I don't. But we asked a question, I am more aware of my ethnic background due to COVID-19. We saw that only 6% of the white publics, but like almost 40% for Chinese and Southeast Asian, like 38%, and then 18% and 19% for South Asian and Indigenous people, respectfully. And then we asked a question to engage internal stigma is, I would find it difficult to tell my friends and family members if I had COVID-19. And we see that 13% of white publics said they would have no problem. But again, the internal stigma of like around 30% for Chinese and South Asian, about 42% for Southeast Asian, and then 15% for Indigenous people. And so I was like, COVID is landing by degree and impact differently around like racial and ethnic categories. And we saw that also for LGBT and Two-Spirit. And so what was our responsibility? And so this came up to the prompting of, we must be more sensitive of how we're communicating and talking about COVID. And so using the NIAID document as inspiration, and I was, R&Ding it, Robin duplicating it, we came up with our own language guide. And we know that language is power. And so it starts off with this quote. So the overall purpose is to assist with the message and content development by using positive, acknowledging, and inclusive, rather than potentially stigmatizing language that may provoke fear. These guidelines incorporate on a broad sense an equity lens, but they're also informed by the Declaration of the Rights of Indigenous Peoples Act that was passed here, and the first of its kind within the country, the commitment for cultural safety and humility in health services, and it also aligned with our PHSA values, which BCCDC is a part of PHSA. There are some limitations. Terminology and language is only is always in a churn and always changing, and so the guidelines highlight current principles and best practices of June, and it I already received some feedback. So it's already, we have to like go through that revision process. There was also a commitment to a biannual review in January and July. It is offered only in English, and it also does not address or include specific sections on graphics and or images. This is only text. The guidelines start off with these guiding principles like language matter, practicing the platinum rule as opposed to the golden rule. The platinum rule is treat others as they wish to be treated rather than the golden rule of treating others as you wish to be treated. The attentiveness that language evolves, using people or person first language and choice and cultural humility. And there's 2 pages around guiding principles that we use to inform and the guidelines. So how to use the guidelines? First, we have to consider the intended audience or audiences when developing content and applying examples, the examples that are provided within the guide. Content developers should have an operational understanding and knowledge of the guiding principles and the suggested alternatives for commonly used words, terms, and phrases. The guide does not capture all potentially stigmatizing language. So content developers should work to ensure that their language, be it even in research and research questions, meets or exceeds the spirits of the listed guiding principles. Here is a list of the various topic areas that are included within the current language guide. And here is some samples of the actual examples of some suggested ways in which that language can be changed. So rather, like we've learned from the HIV activists, that using the word infection or positive, and like the word infection carries a stigma being contagious or a threat or unclean. And so what we want to do is to use value neutral language and use descriptive language. So rather than saying COVID infections or new COVID infections, we say, COVID-19 virus or COVID-19 virus transmission or transmission of virus. And then over there, the word risk on the next page, rather than saying risk, is we can say increase or decrease the likelihood or chances of transmitting COVID-19 virus or getting COVID-19 virus, or like using words like risk factors, we should say chronic conditions, and the list goes on and on. Plus this whole thing around like battle language of fight, battle, attack, we should protect and protection from COVID-19. The nasty V word, here's that V word. I myself being gay, and First Nations, or what I would say is Two-Spirit, I would often be defined as being a vulnerable population. How is it that my ethnicity, and how do I change my ethnicity, and who I sleep with, how do I change that? But yet those are used as monikers and to define me as being vulnerable, where what puts me at vulnerability is systems of oppression, like settler colonization, homophobia, transphobia, racism. And so there is a page that draws into attention from Dr. Amy Katz, is no group or people is inherently vulnerable. If a group or people is experiencing vulnerability in a particular situation, setting, system, or society, that vulnerability is being produced by other people. It is entirely possible to trace how that vulnerability is produced and who is responsible. If vulnerability and vulnerable is used, it warrants a description of how it is produced and who is responsible. And so we must challenge the way our current conversation of public health and research is often used, and that nasty V word.
We're going to have to draw to a close in a minute, if you wouldn't mind.
So where do I find the guide? Just go to our main page. You can find it by clicking any of those. Scan. Quality improvement, the biannual. So if you have any information, would like to provide any feedback, please do so at that email address. And a big thank you to all of the folks who gave of their time, energy, and spirit and support to make this guide possible. Thank you so much.
Thank you so much, Harlan, and sorry to interrupt you, but thanks for responding so rapidly. And I'm glad you got the memo on the dress code for the session, so pleased about that. So we've got a few questions, and actually, just to say again, Harlan, this is just fabulous. This is such a great resource for us to have that underpins our ability to really communicate effectively, I think. So thank you for the work you've done. A few questions that have been coming in that I've tried to keep track of. There was a question about Black people and Black communities. You weren't explicitly making reference to Black people in the work that you've done. Do you want to just comment on that?
So within that itself there is that race and ethnicity, and we deferred to CIHRs and how do they collect ethnicity. And so there's specific guidance for questions. And from that guidance, you can develop your race and ethnicity categories using the federal guidance around that. And so it gives like Southeast Asian, oh, you're talking about the actual survey itself.
The survey, yeah.
Yeah, I have to get back to you on that.
Okay, I mean, I think one of the sort of great things that your work sort of shows is the importance of collecting data on race and ethnicity, and actually understanding what we mean by race and ethnicity, and actually maybe challenging some of the categorizations that exist already, so that we end up with more, you know, ones that actually are meaningful to people. So I think that's, you know, I think that the importance of data and collecting data on that, rather than shying away from collecting data on race and ethnicity, I think is, for me, like a really important piece. I can actually see someone with a hand up. I don't know if we're actually for our. I don't even know if you're able to speak at this point. If you are, then I'm very happy to take your question. But otherwise, please feel free to add it into the chat.
Yeah. Can you hear me?
Yeah, we can. Great. Okay. Just quickly, if you could, because we're almost out of time.
Okay, Harlan, thank you so much for doing that. I think it's really important. In global health, we've also found that there's quite a lot of stigma in various communities. I just wanted to ask you about the V word, because often I work in sexual health. We often use that for vagina. So that was very cool to see that there's a lot of V words. But as somebody who does anti-racism work, we often look at vulnerability from a structural perspective, and we find it really important to point out structural and systemic inequities. So vulnerability for me, or marginality, has been a way that we've talked about that. And I just wanted to ask you about your reflections in that area.
Sure.
Just briefly, Harlan, if you could. Thanks.
Sure. So I think that the way in which that you actually used it, of like you're defining it, and you're just not using it. But often when I see the word vulnerable and vulnerable populations, it's not defined. And as Amy Katz showed in their paper is that when it's not defined, and clearly it is posited on the individual, like me, my ethnicity, or me, my sexual orientation, and I'm the problem. And so it is, how do we look at the system and the systems of oppression, and how do we draw that into focus? And that's where we should be looking for the changes, but it also implicates the researchers and the folks that they may be part of the systems of oppressions.
Great, thank you very much, Harlan, and thanks so much. So the chair has not been great in this session, and apologies for that. We're almost out of time. I'm going to have one question that's come from a patient that I do want to just sort of share. So, and I'll ask you just to be very, very brief in response. So the question is, I struggle with how patient-oriented research and patient engagement may have been left behind during the emergency response to COVID-19. So how do we rebuild trust and awareness with patient partners? So I'm just going to ask maybe anyone who wants to give a quick response to that, feel free to do that. Maybe we, if Kim, could you start us off just very briefly in response to that question? Has patient orientation been lost as a result of COVID or not?
It's such a hard question, really. I don't think so. I mean, what I have observed in COVID-related research is that people have been really careful to bring in patients. There's been lots of activity. I think in some sense we risk overburdening people, but I think there's been lots of responsiveness. And I think that's spilling out. Like, I think it's less and less acceptable and more questioned if you don't have the voice in there. I would underline that a lot of the work I do is more about public involvement, or at least as much about public involvement versus patient involvement, which is, I mean, it could be the same people, but it provides a different perspective, right? So I think we need to be open to all of those things. And to borrow one of your phrases, Sterling, it's the horses for courses. But I think, like so many other things, this is maybe is a turning point, and maybe we can get to the point where we just won't go back to thinking that we'll do research without those voices.
Okay, thank you very much. And I'm sorry that we've got to cut it at that point, but I just wanted to sort of raise that issue so that we can keep the conversation going around the importance of ensuring that people with lived experience are part of COVID research, as well as part of health research more generally moving forward in BC. And just as a closing comment, I think that COVID has brought some culture shift in BC. I think we're actually moving towards a much more collaborative spirit and a collaborative approach. And the supports that we've heard about today, I think are a reflection of that. So I just want to say a huge thank you to all of the speakers and to the people who've organized the conference, Peter and Tanya in particular, and Kat. Yeah, enjoy the rest of the day. I look forward to engaging in further conversations. So I'll hand back to Peter, I think, at this point.
Great, thank you, Sterling. And I'm going to rebut your self-deprecating comment about the quality of chairing of that session. I think you did a great job, so thank you very much. And thanks to all the speakers. So everybody take a deep breath. We're right on time. Some of you may need to run off and do some whatever personal things you have to do. But in the meanwhile, I'm going to hand off the chair to Professor Craig Mitten from our School of Population and Public Health at UBC, who's the chair of this next session 6 on other impacts of public health measures and that exceedingly gentle term, unintended consequences. Craig, are you there?
Great, thanks, Peter. Good morning, everyone. Wonderful to see so many people again on day 2 of the conference, and I think it's going swimmingly. Good job on the chair. Sterling, I'm going to echo Sterling's comment that I am really bad at multitasking. In fact, I'm worse than Sterling because I am not on social media, and much to Sterling's chagrin, I do not tweet. So I find it very hard to read chat rooms and listen to speakers. So I'm going to encourage in this session that people do put their hand up using the Zoom raise hand function. And I'd encourage people to shout out their questions live, although you can still use the chat box. I will be having more challenges likely than Sterling did on that front. So what we'll do here, we'll turn it over to our first 2 speakers. And we will then have, they'll have 10 minutes, and then we will have a few minutes for questions right after each presentation. And then we'll probably have a few minutes at the end as well for some general comments. So I'm going to turn it over to Vicki Knight and Kim Sebahazi from UBC Faculty of Education. If you two are ready, and oh, I see you there. Fantastic. So turn it over to you guys. Welcome, and 10 minutes for you two.
Great, thank you. Thank you. Can you all see the, oh, yeah, just do start show. Whoop. Can you all see the slides?
Yeah, looks good.
Okay, great. So I'm Dr. Victoria Knight. And I'm Dr. Kim Sebahazi, and we're at University of British Columbia in the Department of Educational and Counseling Psychology and Special Education. And we're going to share with you today some impacts of COVID-19 on special education based on a survey that we conducted. And we will be sharing some preliminary results. We were lucky enough to have those, and so our format is slightly different than the recommended format. I want to start out by just giving us a little context for the current research. As you know, there's no more face-to-face learning, so we have moved entirely online, as we all know. This has affected our districts primarily because of the quality and quantity of information. We just weren't prepared for this pandemic. But this lack of preparation has left many children behind in general education, but especially in special education because of the varied supports and needs that this population has. And special educators have been left alone to really try and innovate and figure out how to make this work for all of their students. The populations with whom we work, in the current study, we ask parents of individuals with disabilities, including those with autism, blindness or visual impairment, deaf or hard of hearing, deaf blindness, developmental disability, emotional behavior disorder, multiple disability, orthopedic impairment, specific learning disability, and speech and language impairment, and other. We had another category. So we really tried to encompass all individuals with disabilities. As a side note, I specifically work with individuals with autism and ASD, and Dr. Zebahezi works with individuals with blindness or visual impairment. In the survey that we conducted, we had a total of 265 responses. The location was primarily in Canada, and the majority of them were from British Columbia. We did have 26% from the United States. In terms of parenthood and partnership, 16% were identified as being single parents. 83% stated having a partner. The age ranges were primarily 36 to 45 years old, and gender was 91% of respondents identified as female. The disability categories most identified were autism and ASD, followed by visual impairment, which we wanted to note is unusual because these are typically the 1% or less than 1% of the population. And those were followed by developmental disabilities, emotional behavior disorder, and multiple disabilities. In terms of ethnicity, the majority identified as white, and that was followed by Asian at 7%, 2% Hispanic or Latino, and 1% Indigenous. In terms of employment, the other we identified as probably likely this was status quo, so whatever they were doing before the pandemic, but we're not really sure unless they identified that. So those results are pending. The next highest was 33% working full-time at home and 12% laid off or employed, and a similar percentage of essential service. So the aims of the current research were, the purpose of the study was to survey parents and guardians of children with special needs on how COVID was impacting them in terms of their coping, their children's coping, their families' coping, what current supports they were receiving now that the pandemic hit, and this was relatively shortly after the pandemic really started to take hold over BC, and the main challenges that they're having with their children and the school districts. So the information that is gained from the survey will hopefully help educators and other service providers to better understand the family perspective and learn from these family strategies when planning supports during unusual circumstances such as the COVID-19. Our timeline was fairly quick, so between April and May, we were able to distribute the initial survey. By the end of May, we provided the initial survey demographics, and those were the ones that we just shared with you. From May to the present, we've launched follow-up surveys, and those include a total of 4 to 5 follow-up surveys. There are 5 questions each, very brief, and 2 have already been launched with results pending, and 1 will be at the beginning of the school, so around September 10th, maybe a week later, and then 1 will be a month or 2 into school, so that we can see the changes that are hopefully going to take hold now that schools are a bit more prepared for this pandemic. We're hoping that the results are a little bit more positive. The data is currently being analyzed. We're using a mixed methods approach, and we're primarily interested in looking at the difference between the groupings based on the demographics that we shared with you. We hope that we'll be able to publish this research and to provide knowledge mobilization so that agencies and districts can provide supports to parents. Okay, some of the preliminary results that we have so far. In the area of coping, the general trend is that families don't feel that they're coping very well, particularly during the time of the survey when things are just getting started with kids being at home for school. And 80% of the families who answered the survey felt that as a family with children with disabilities, that their situation was more challenging than families without disabilities. And only 17% agreed that they can balance the needs of their children with and without disabilities equally. So they're having some struggle between this balance of working at home and having, for example, and having their children plus a child with disabilities that may need some extra support and time. In terms of current supports, the general trend was that some supports were still being received. However, they've dropped in frequency or quality from 10 to 25%. And an interesting thing too is that we asked them to identify the supports they had been receiving in school and which ones they were still receiving to a certain level now that they were having online learning and virtual learning. And the initial percentages, unfortunately, were not great to begin with in terms of the supports they were receiving in school, but then there was an additional drop in terms of being at home with COVID. And only 24% agreed that the school provided a useful plan for teaching their children with disabilities. So this is a good highlight for schools moving forward. Should we be in a situation where face-to-face learning is going to still be restricted and might have a hybrid model? We're not sure exactly how things will play out. Should that happen, this is a take-home message for schools to support parents in a way with a plan, help them understand how they can best provide some support to the children. And 83% are worried about the long-term effects of their child's development. So what's going to happen when the child does go back to school after all this lag in time? They feel that they didn't provide their children with enough learning, perhaps, and so they're worried about arrest in development. Some of the main challenges that have been identified, this varied depending on families' ability to meet basic needs. So some families were in this midst of just trying to find money for food, and so their needs were different, obviously, than families that had that more under control. Concerns for the children included lack of social interaction now that they were all only at home, lack of routine, which is often a very important aspect for children with disabilities, the parents having to become the primary teacher, and not receiving any breaks or respite. And this was particularly true for parents who identified that their children had some significant behavior challenges. Some representative quotes include, "I'm shocked and horrified that it just took a pandemic about 1 month to strip our most vulnerable students of their rights. My heart is broken." So there is some concern that this is opening a door for school districts to not provide as much as they were before, or to basically forget about students with disabilities, particularly since they are still struggling with providing how to best provide education for all the students. Students with disabilities have kind of fallen to the side a little bit. And then on a more positive aspect, a parent said, "All first world problems," in terms of being in North America, "and I try to reframe things as examples of our good fortune to minimize upset. We have a home, running water, food." So one of their coping strategies was saying daily gratitude lists alone and with my son. So how might collaboration and partnerships overcome these challenges? So we're looking at how could school districts and agencies involved with children with special needs work with parents in a way to overcome some of these challenges that were identified in the survey. First and foremost, in terms of inclusive education and inclusion, there does need to be an increase in better efforts for including children with this change in instruction. How can we still make those children feel part of the school community, part of their classroom, when we're maybe a hybrid model, for example? And then also increasing the amount of contact and check-ins parents receive from teachers. In terms of support, some of the most, parents were asked which supports, what they could add, if they could ask the schools for something extra, what would they ask? And the most frequent responses were access to more one-on-one or in-therapy visits, which might be more practical now that we're in a phase 3 of our reopening in BC. And providing developmentally appropriate materials. So providing materials for the parents to use at home with their children, because that wasn't happening. The stuff that students had at school to use that was unique to their learning needs weren't given to parents to use at home, and so they were left without those resources. Increasing the virtual support and increasing respite opportunities.
And if you could just wrap up here too, that would be great.
Yep, this last section. And then finally, the access to being more compassionate with parents and checking in with the parents' needs and responding to those needs in order to reduce parent guilt that they're not capable of working with their children, and increase their feelings of incompetence. And that's all we have. Thanks.
Excellent. Thank you, Vicki, and thank you, Kim. Fantastic. Certainly one of the most highly discussed topics right now, with back to school on the horizon, and then just a wonderful study you've given us with families dealing with even more challenges than just having little ones at home. So thank you.
Yes.
A couple of questions have come in the chat box. And if anyone else does want to raise their hand with the Zoom function, we'll try and spot you and give you the floor. It sounds like Sonia Cressman's asking, how might access to diagnosis and underdiagnosis affect the results? 1 year loss between ages 5 to 7 might be highly impactful.
Well, I would think that they would be more impacted, right? Because if they're not identified as having a disability, in order to even receive services, you have to have a disability category or disability label. So if they're identified as being within the general population, but they actually do have a need for an individualized education plan, then they're really falling through the cracks, I would say, even more so than our students who receive the services. Does that answer the question?
Because they may have been receiving some supports in school unofficially, but that wouldn't be transferred. Like those parents wouldn't have access to a special educator, for example, when they now have to work with their child at home. So I think I agree that they would be more, I don't want to use the V word now. They would be more at risk to, fall through the cracks.
Great. One more quick one, just a question about how to define coping. How do they define coping here? How do you define coping?
Coping, we defined, the questions were around what they were doing to basically deal with whatever situation they had. And we asked both positive and negative coping strategies. So we were looking at what they were spontaneously, organically coming up with to create routines in their home, get things going. And that's how we talked about coping.
And those were open-ended questions because we didn't want to put ideas into like meditation. We originally had the survey as having them check boxes, but then we really wanted it to be a little bit more organic, but we did define that as either positive or negative coping strategies. And one theme that did come up were negative coping strategies, right? So lots of TV watching for their children, and they were coping just by letting the TV be the babysitter, so to speak. Increasing alcohol consumption, tobacco, substances was also a common theme that was a negative coping strategy.
And on the flip side, there was a smaller group of parents who said that their children were actually doing better because they didn't have the social anxiety of being at school, or bullying issues or whatever at home, and so they felt that their child was coping better. However, they may not be getting the practice opportunities to deal with those issues in the long run.
And it seemed to correspond with the severity of the disability. So if the severity of the disability was higher, they tended to were coping actually better, which was an interesting finding because the students weren't having to, they weren't engaging in more challenging behavior because they weren't being asked to do things that they didn't want to do, right? So they were kind of left to their own devices.
Great, thank you, fantastic. Really appreciate the two of you providing the talk and information. There's a few other questions that have come up, and if the two of you wouldn't mind throwing in some responses there, that would be fantastic. We will move to our next speaker. That is Kafu Manu, who's a professor in commerce at UNBC in Prince George. Welcome, and please go ahead.
Okay, I just want to make sure that that everybody can hear me.
Yes, perfectly. Thank you.
Excellent. All right. As mentioned, I'm from UNBC in Prince George, and the work that I'm going to be talking about today is the data gathering has been done a while back, but it's focused on looking at working from home. For those of you who do not know, there is a lot of research and work on telework. This is not new, and remote working and so on. It was prior to the pandemic. There was a survey done for several different corporations, and they said at the very least in the next year, 5% of our knowledge work, I'll talk a little bit about what that means, will be moved towards telework or remote working. And usually for those who were involved in this in the past, it was considered productive. However, there were caveats. First caveat, high emotional stability was important for telework and remote working. So those who felt that they needed emotional support found that in the office and talking to people, but those who found their emotional support and stability outside of work found teleworking to be fine. Another issue that came up, again, prior to COVID-19, I'm sure we all know about this now, is the work-life balance disruptions. So there's a time of adjustment, let's say, before you are able to determine exactly when you should work and so on, and work is not taking up all of your life. And lastly, it is the issues of team size and technologies that are used when creating telework or remote work are also very important, depending on the tasks of the workers. So one particular study looked at synchronous versus asynchronous communication amongst telework employees. So things like Slack, for instance, where you keep these applications on literally the entire workday, so that you can be almost interrupted in your office, like if you were actually co-located. And also the size of the team, where a very large team, there can be problems with telework. However, the situation that we're in is more than telework, as again, we all know. So here I just have a very brief timeline of the events that occurred within BC before we had our lockdown. And as we know, this was very quick, and companies were scrambling to be able to deal with this. And so this is not like normal telework. It's during a pandemic, it was quick. How did this abrupt change how people dealt with remote working in their lives? And so that's one of the things I wanted to look at. So major questions that I cared about were, how are people coping with being forced into remote work? How are people working in this new environment? So are they productive? Is there any connection between productivity and well-being in this case? And again, because we're in a pandemic, questions of disaster preparedness or fear or so on, especially in those earlier days, do those have an effect on how people work or feel that they're working when they're doing telework? And then lastly, one quick item that I thought of was this question of home office environment and ergonomics. So how does that affect the productivity and well-being of individuals in this new environment? And so, as I said, this focuses on knowledge workers. So by knowledge workers, we're looking at people who share information and turn it into knowledge, people who manage work, who communicate. And if those particular tasks, people who perform those tasks, are they doing better in this pandemic than others? And I'll show you a little bit of what those tasks are.
Kefu, can I just ask you to lean a little closer to the mic? It's just going in and out a little bit.
Okay, sure, not a problem.
Great, thank you.
Yeah. So then, what from these questions, I first did an online survey with respondents to see how people were doing. And as I said, I focused on knowledge workers who were forced online. So there are some people who have been working online for this entire time and there's no difference. So one particular company that I talked to, they said, we've been doing this for literally the last 5 years. There is no difference between lockdown and our normal operations. I'm like, okay, you're not exactly the people that I'm looking for. However, I gathered 110 respondents. Unfortunately, 20 of them had no eligible data, and 78 of those people filled a full survey. rather than half of it. I use 4 validated measures for well-being, perceived productivity, disaster preparedness, and fear and resilience. The other one, organizational support, which has some interesting results, was not a previous measure. However, it was also validated. And all of this was gathered on April 13th to 27th of this year. So the participants, as I said, I wanted to focus on the sort of tasks that people performed. These are essentially breakdowns of the different types of knowledge work that you can do. So monitoring, connecting information together, creating connections, communication, and so on. The majority of people that were in this survey were people who dealt with a problem. So they were problem solvers. You'll also notice that the numbers seem pretty high in comparison to the participants that I have. As you may have guessed, many people have do multiple tasks. And so they may be showing me that they did 3 or 2 or 4 tasks in their normal work. Also, a lot of the participants work in organizations that are large. So again, here, the majority of them work in institutions that have 1,000 to close to 10,000 people. So these are not small organizations. Geographically, the majority of people were in Canada. And the gender split was even with male and female. 3% of the respondents did not respond to the question, while 3 put other. So just some preliminary results, because I do want to be able to do some regression analysis and PLS to make some connections to these different types of areas. So disaster preparedness versus satisfaction with work and so on. But these are just the numbers that I have currently, and they do provide some interesting things. So the first is that we asked people before the pandemic, so think 28 days before you're taking the survey, how did you feel about your work and how did you feel about yourself? So were you in good spirits and so on? And the majority of people are skewed to the positive. After, when they were working at home, there's a slight dip, but nothing significant. So the majority of people, at least in this time, there was no big issue with well-being. The other thing, as I mentioned, I wanted to see if organizational support could help people. So what I did is I took about 20 different things that a company could do with remote workers and see if people found it helpful and if their company was actually doing it. And so I'm just going to pick some highlights to talk about. So the first one was a support which is helpful, but people are not providing it. And so the majority of people, I'm sorry, that should be over here, which is true, but under here, sorry, which is that it is true that people are providing it and it is helpful. So this should be highlighted here instead. Sorry about that. So the majority of organizations and companies did not provide a lot of things that people felt were helpful and true, except for taking equipment home. So a monitor or something like that, people found to be helpful, and also that their organization were doing it. That a lot of people wanted that their organization was not doing was paying for all of my internet charges. So providing internet, and another thing which I did not put here was, it was slightly less, about 50 people instead of 54, was providing software that I needed to do my work as well. So those two things were things that organizations should be doing that people found helpful, but were not. Interestingly enough, things that people said that their company was doing but was not helpful were having regular meetings via video chat. The continuation of this synchronous work is not something that people care to have. And this is not surprising when we look at research prior to COVID-19, when we look at software developers, One of the reasons why applications like Slack are created, where you can essentially open up this application and it's almost like your office is on your computer. And then you can go in, talk to individual people, have a meeting, send text, whatever you need. The reason why those became so popular amongst people who do telework previously is this idea that you're not continuously being forced into a meeting or a video chat, but you can interact and have social connections when you want to. So this is not surprising.
Kafu, you're just pressing time now. If you could wrap
all right, sure. Sorry about that. And yeah, I'll just wrap it up. And so other things that I found from the numbers is that people are fairly resilient, actually, in my sample at least. There's a split as to how fearful they are, but they do feel fairly resilient, at least at the time. And the working environment, again, is slightly a bit more positive. They feel that they're getting the right sort of ergonomics for what they're doing, but it is split amongst positive and negative information results. So some of the challenges in the collaboration that I'd like to do, first off, low variability in location. The majority of people come from Canada, from Western Canada, actually Alberta and BC. It'd be nicer to have a variety of people in the subject pool. Limited number of respondents, in that it'd be better to have, this is a very large group of people, a large population. And so to extend this to see if these numbers still hold. And a question of scope. So another project which I am not a part of, but a friend of mine is, focused directly on software developers only, not knowledge workers as a whole. So this is another question of this research is, should I keep this large scope or limit it to a particular area of a knowledge worker? For instance, somebody doing telehealth, for instance. And that's where future collaborations, I think, may be very helpful for this research. Thank you very much.
That's fantastic. Thank you very much. We do have one hand up, so we'll just take that. Kat, if you could unmute Farah Shroff, we'll get a question from her, please.
Hello there. Thank you so much.
Just briefly, we're running short on time.
Yeah, thanks so much for that wonderful presentation. I did want to ask you if you could talk a little bit more about the ergonometrics of working from home, particularly if people are working primarily on laptops and what that's doing for necks and backs and eyes and all of that. Was that at all covered in your work, or is there any kind of support? Do you foresee, for example, any insurance claims coming out of people having workplace injuries in their home environment? That kind of thing, I think, is rife for at least public health stuff.
Right. No, that's very true. Unfortunately, I'm in the business school. So we just ask people if they're comfortable or not. That's it. So we looked at things, comfort, like ergonomics as in chairs, your level of distraction, and like heat. But that was it. However, we are aware from other research that the cost of setting up a home office is quite substantial. And it used to be that for teleworkers, some companies would provide funds to set it up. Now that everybody's doing it, though, that hasn't been something that people have done.
That's great. Thank you. It's certainly a fantastic topic, and one which is on all of our minds during the pandemic and then post-pandemic, what patterns are going to continue potentially, and certainly a question on many people's minds. So thank you for the excellent presentation. We're going to move on to Dr. Simon Pimstone. Simon is affiliated with UBC and is a clinician. And he's also a fellow soccer dad of mine. Our girls play on the same soccer team. And Simon, looking forward to seeing you hopefully back with some games coming up in the fall. Simon, over to you.
Thanks very much, Craig, and hope everyone can hear me okay. It's a pleasure to be here. I'm going to talk today about a new study that's being launched, a study we call SAFER BC. It's known as the SARS-CoV-2 study for eased restrictions in British Columbia. Just a brief disclosure, I am one of the principal investigators of the study. I'm also CEO of one of the participating sites. Xenon is a publicly traded biotech company. And just another point to make is that we have submitted the study for ethics. It has received funding. We haven't yet heard back from ethics. So we do expect the study to initiate once all the relevant ethics approvals are in place. So why a study of COVID in the workplace? I don't need to spend too much time on educating this audience. It's obviously an unprecedented time at many levels. And one of the big challenges, of course, is the interconnectedness of our world and our workplaces, trade back and forward, travel back and forward. And really, as we sat down to think about bringing people back into our workplace, recognized quite quickly that there was really no relevant data to drive guidance. We were using our best educated decision processes, but really not based on any valid data from similar type periods in time where we at least had information that can help guide employers and employees in how to optimally manage the workplace in order to minimize risk and maximize productivity. And of course, apart from the tragic health consequences and the incredible social consequences of COVID, the economic consequences, which of course underlie much of the health and social disturbance, are very significant. And this is data from both Canada and BC in terms of GDP and unemployment. And I'll just draw your attention to the forecasted 2020 unemployment rates relative to where they were in 2019. This data is a little bit old. Of course, some of our jobs have been regained in British Columbia, but I think with the second wave, and possibly that being quite extensive, I think we do run the risk of seeing unemployment rates rise further and significant impact on decline in gross domestic product. So what is the study that we're about to launch? This is essentially a study of a large cohort of employees and students in the workplace in British Columbia. This will be run in a controlled clinical-like trial setting, which will allow us to collect data and to make that data available to inform public health decisions and also to inform workplace decisions. We're thrilled by the support we've received from Genome BC and Genome Canada, who have funded the study, and in addition, with significant in-kind support from our industry partners. I'm leading the study together with Dr. Tanya Bubella from SFU, Dr. Joseph Penninger from UBC, and Dr. Mel Cragdon from the BC CDC. And this, I think, speaks to one of the points Sterling made earlier, which is the importance of collaboration and really the absolute criticality, I believe, in a problem of this magnitude for public and private institutions to work together to help to solve the problem. The elements of the study are really outlined here. We will be tracking and collecting data over a 12-month period on infection rates, immunity, contacts within the workplace, and clinical symptoms. We'll be studying a large group. This is the largest study of its kind, we believe, certainly in Canada and possibly worldwide. 1,500 volunteer employees and students and trainees at BC-based biotech companies and post-secondary academic organizations. Also, a very important element of the study will be a survey that will collect psychosocial information related to the pandemic in the workplace. And this will be run by Laurie Brotto and her colleagues around the important impacts of COVID in the workplace on mood, anxiety, stress, etc. The participating centers will be 3 of our large biotechnology companies, Xenon, Stem Cell, and Zymeworks, as well as our 2 large academic partners, the Health Science faculty at Simon Fraser and the Life Sciences Institute at the University of British Columbia. All within the life sciences community. We can speak in question period as to why we chose this. We clearly recognize this is not reflective of the broad population in British Columbia, but we felt was a good place to start, given their knowledge of science, their knowledge of clinical process, and the importance of that in collection of a good, clean data set. The objective of the study, briefly, primary objective will be to determine the SARS epidemiology in this life sciences workplace cohort in this province, establishing the incidence of SARS in employees and students as measured by PCR, and also to establish and monitor the serological status in employees and students. We'll be measuring serology at baseline, at 6 months, and again at 12 months to look at conversion rates in a large cohort of back to work students and employees in the province. There are a number of secondary objectives. We'll be looking at how we may be able to implement changes to the back to workplace guidelines as the risk levels change, as those risks go higher or lessen. We're looking to obviously establish and implement guidelines for managing the workplace when employees or trainees develop COVID symptoms or test positive for COVID, or when a household or close contact of the employee or student develops COVID-like symptoms or test positive. These are already circumstances we're facing in our business on a regular basis, and we'll see a lot more of that in the months to come. We're very interested in monitoring the workplace as guidelines hopefully relax over time in keeping with BC provincial guideline changes. And also, as I mentioned, determining the psychosocial impacts of this particular pandemic on our staff, on our trainees, in order to optimize workplace guidelines, programs that we can offer, and hopefully to help with public communications. We're interested in using this cohort to identify contacts, and so we will be doing contact tracing, identifying the clinical presentation of COVID and analyzing causal risk factors underlying the spectrum of disease. What are those factors that may predispose to asymptomatic infection, symptomatic infection, or severe symptoms? We are also interested in identifying viral clades, the origin of the viral viruses, to where they come from, particularly as borders restrictions get loosened and many of our employees and or students are traveling back and forward. We're looking at correlating infection with symptoms, with predisposing risk factors, clinical status, and demographic and workplace risks. And lastly, we look to do work on linking the viral genomic sequence with the viral origin as well as the host proteome to understand host immune responses to this infection. The study will be managed by EMIS. This is an internationally recognized contract research organization. They have a subsidiary here in British Columbia. They have deep experience in managing public health. The diagnostics and serology testing will all be performed by Life Labs in collaboration, and a local digital app developer, Thrive Health, will be developing all of the digital applications to collect data and transfer that data to our public health system. The BC CDC will store the data, will analyze the data, and will report on the data. Just to wrap up, we're very excited by this project. We have now submitted this for ethics approval. Based on approval from the CREB, we expect our first subjects to start enrolling in October. Each subject will be followed for 12 months, so all participants should complete 12 months of the study by next year, December, and we should have final data acquisition complete early the year after. We should have data cuts during this study that we can make available publicly, and that will have to be discussed with BC CDC and Ministry of Health in how that gets communicated. So it's a study that I think is quite unprecedented. We're very excited. It's a very large study. It's unique to Canada, and we think probably unique worldwide in terms of its breadth and scope, and an aspirational study. But I have to say, I'm really, really proud to have been able to be part of this together with our colleagues at SFU, UBC, BC Centre for Disease Control, and some of the other leading life sciences organizations in the province. So Craig, I think with that, I'll stop and take questions later.
Excellent. Thank you very much, Simon. Excellent. Really exciting study. One question that comes to my mind is around generalizability with the biotech focus. What are your thoughts on that?
No, I think, look, it's if one had to have a major criticism, that is it. And we've recognized that going into the study. The challenge, Craig, is, it's a very tough study to operationalize. This is extremely complex. And so, where one might have recognized obvious candidates being, for example, long-term care facilities, food packing or food processing plants, where clearly we've seen very meaningful outbreaks over the last number of months, we felt it was important to try and get over some of the key hurdles in how to operationalize a study like this. And so focusing in this community allowed us to do that. Now that we've got a protocol this protocol could be extended, not just into other sectors, as we hope it will, but potentially into other geographies beyond British Columbia. It's a very, very thoughtful protocol that's had a lot of input from our Ministry of Health officials, our BC CDC, our companies, the British Columbia Business Council, and of course the academic centers that we're partnering with, SFU and UBC. And so I think we've got a nice platform from which to springboard into other sectors as interest arises, and we'd be certainly happy to share all of our lessons learned in enabling that.
That's fantastic. Thank you for the link that was just posted in the chat box. I think this is really fantastic work. One final thing for me, Simon, we do have 30 seconds left. Just wondering about, I've looked a fair bit in recent weeks on WorkSafe BC with their safety protocols, their guidelines, their many protocols. How are you interacting with what WorkSafe BC is putting out, and how does that kind of potentially play in with the findings that you might come up with?
No, that's absolutely a critical question, and I should have mentioned that. We are following all of the WorkSafe BC and provincial guidelines in the back to work recommendations as part of the study. We are working extremely closely with the BC Centre for Disease Control, and through them and PHSA will interact with WorkSafe BC. This study will not be putting in place guidelines in the workplace that are at odds with those that are put out by WorkSafe BC. We'll be following their recommendations, but it will be essentially a learning laboratory, so to speak. As their guidelines change over time, we're able to monitor such changes in the workplace and to determine with data collection objective data as to how the changes in these guidelines, hopefully relaxation of guidelines over time, may impact. And now, again, we would love to have this study be more extensive, reach in other sectors, potentially other geographies, to make it broadly applicable. But again, as I said, we had to start somewhere. So we'll work hand in hand with the province in terms of the guidelines specifically, Craig, as part of the study.
Excellent. Thank you very much, Simon. Looking very much forward to seeing the study unfold and the results to come. Let's turn now to Valerie Crooks from SFU for our final speaker in this segment. Valerie, if you are online and would like to share your slides, the floor is yours.
Thank you. Actually, I don't have slides to share. I was accidentally dropped from the speaker's information and so didn't prepare them in advance. That's what happens when you're left off of an email list. So I'm going to present and tell people about a study that we have had funded through the Michael Smith Foundation for Health Research competition. Back in the early days of the pandemic, many of us who are in the research community would have seen the Michael Smith call for proposals. And one of the things that really struck me as a health geographer was one of the funding objectives they were seeking to actually pursue was looking at what they called human geographic considerations in British Columbia with a view to preventing transmission and mitigating effects. And as a health geographer, it's not all that often that a specific objective for a research proposal competition catches my eye, but I thought, well, I must be able to respond to this particular aspect of this call for proposals because in many ways, health geography has actually never been so relevant to helping us understand a critical global public health issue, or even to help with creating supports and identifying solutions to eliminating infections and addressing impacts. So I connected with a long-term collaborator of mine, Dr. Nadine Sherman, who's a GI scientist, also based in the Department of Geography at SFU, which is where I'm located. I'm a qualitative health services researcher, and we have a long-standing collaboration around building vulnerability models that we have worked on together for over a decade. So we put together a proposal to the Michael Smith Foundation for Health Research call, and it was picked up for funding. And then in addition to that, we've received funding through the BC Support Unit to incorporate patient partners in this research. So because we're still at a fairly nascent stage in building the models that we've proposed, I'm going to, in this presentation, talk to you about what it is that we're working on and where we're at. Unlike some of the other presenters in this session, I don't have preliminary findings to share. So the goal of our work is actually to use spatial data. And what I mean by that is something that has a geographic reference point. So a piece of data that has a postal code attached to it, an address attached to it, or some other geographic indicator. We're using that spatial data to actually produce a series of sophisticated maps that will actually help us to identify specific locations in British Columbia that are at risk of having local residents experience potentially high rates of COVID, of also having inadequate spatiotemporal access to ICU care in the event of severe cases, as well as those who may be at risk of experiencing secondary health effects of the pandemic. And so the goal of this project is to create maps that are effectively decision support tools. So the intent is not to create maps that on their own should be used to guide policy decisions, but should be used in conjunction with epidemiological data and some of the other sources of data that are being used by units such as the BC Ministry of Health in order to create a new tool that they can use in their decision support system. So what we're doing in our project is we're actually creating 3 distinct models. We're calling them the CORVIX models, or really coronavirus vulnerability index models. So the first one is that we're identifying dissemination areas, where a dissemination area is really typically the smallest geographic block that you're able to get socioeconomic data at. So usually it's a block of 300 to 500 citizens in a neighborhood. So we're looking at identifying dissemination areas that have high rates of residents that could actually be at risk to COVID-19 transmission. Our second model is looking at dissemination areas with residents who are potentially at risk to experiencing inadequate spatiotemporal access to ICUs to treat those complex cases. And then our third model is to identify those dissemination areas where residents are likely to experience the secondary health effects, not of COVID-19, but of the pandemic. So including some of the policy measures, the financial measures that are doing things like creating stress and negative mental health circumstances, as well as other health indicators. So we're incorporating 2 different types of spatial variables into our model. The first are individual risk factors that we're drawing from census data at the dissemination area level. The second are what we're calling amplifier sites, and these are specific locations. So, i.e. places with a particular address that introduce a particular kind of place-based risk. So these amplifier sites may include things like workplaces that we know have risks for outbreaks. So for example, some of the agricultural production occupational sites. So how we're actually building our models is that this is done in a really iterative way. So we have a number of steps that we undertake, and then many of these steps actually lead back to loops where we go back to the first step or go back to the step before in order to sort of move forward in building the model. So the first thing that we do for each one of these 3 models is that we actually look to identify variables that we could potentially include based on the scientific and popular literature. So among our team, and our team is led by myself and Nadine Sherman, we've got 2 graduate students working with us, 2 patient partners, and a research coordinator. We've had a number of meetings where we're identifying variables based on the scientific and popular literature and talking about the viability of including each one. So variables ranging from sex to exposure to air pollution to occupational hazards, a number of the other things that are talked about that we see coming up and that have been discussed in presentations throughout this conference. The second thing that we do is really assess the evidence for including a particular variable with our team. So we kind of go out and say, all right, what is the existing evidence that tells us how we should interpret this variable? And sometimes our thinking changes. So actually, it's very interesting. Our proposal to the Michael Smith Foundation for Health Research in many ways is a bit of a time capsule of the variables we thought we would want to include when we wrote the proposal. And the evidence around, for example, some of the sex-based evidence with regard to COVID risk has really changed over time. The discussion around the potential risk for people who are smokers. So we actually look at the evidence and we want to have an evidence base. So we want to have a rationale for including a particular variable. in our models. So right now, we're actually at this stage in building our first model. We're at the stage where we're assessing the evidence and going back and forth around the variables we want to include. The third thing that we're doing to build these models is actually to conduct surveys with medical health officers or people who are similarly situated within the health authority jurisdictions in order to confirm the inclusion of particular variables and identify others that should be considered. This is a really important step in building this model, and this follows other types of similar models, vulnerability models that have been done. We're really hoping to be able to do this soon. We've been caught up in a bit of a loop with the harmonized ethics process. And so at this moment, we're unsure. We may need to move forward without having these surveys completed because it's holding up our progress in the study. The next step that we undertake, and we're at the point of being able to start doing this, is actually to build our preliminary models where right now all of our variables are weighted equally and create the map outputs. And of course, we're using GIS to build the models, but then of course we need to think really carefully about our cartography. So our actual visual demonstration, what these maps will look like and how they can be interpreted. And then this leads me, I should say, to mentioning sort of the fourth key step, which is that we aim to conduct interviews with intended end users, so people in administrative positions, in health authorities, and other similar units, where we want to actually do interviews where we show them the maps, talk through the maps, and we get feedback on the components of the model, on the actual visual display, the cartography. So sometimes you can change a color in a map, and that will change somebody's understanding of what's being shown. You shift the scale of display, and suddenly something that looked risky before is not risky. So this actually requires a lot of careful consideration. And then also feedback on the interpretation. What information do we need to give people so that they can interpret the significance of what's being shown in the maps? So again, we're sort of right now in the process of seeking ethics approval, going through the harmonized process to be able to do these interviews. And then our fifth step is really to revise the model based on any information that we get from those interviews, whether we revise the model or we revise our mapping outputs based on the cartographic insight. So this is the work that we're undertaking. It's a really dynamic, interesting project. We're having a lot of really strong, engaged discussion with our team, including our patient partners, and we're moving things forward, and we're hoping to be able to have some mapping outputs to share widely and not just among our research team in the not so distant future. Thank you.
Excellent. Thank you very much, Valerie. Just one question that came in from Christine as you were speaking. How do you define adequate access to care?
Oh, with regard to the model where we're looking at the ICUs. So in that case, because we're using a mapping-based project, we're going to actually be using real drive time information and drive time data. So we'll be looking at a geographic drive time catchment around that, potentially 1 hour, using real road time data as opposed to crowfly data or crowfly process. But that's what we're going to be doing for that. And again, the access component is only looking at spatial access.
Great, thanks, Valerie. Farah, you have a question to pose. Kat, if we could unmute Farah, there we go. Go ahead, Farah.
Hi, thank you so much, Valerie. That was amazing to hear what kind of health geography data you're collecting. I wanted to ask really specifically about the secondary impacts of the pandemic, because you were talking about sort of public health measures and what you're collecting. And I'm wondering, like, the three that I can think of right off the bat are violence against women, mental health issues, and opioid overdose issues. What are you collecting? Which categories are you working in?
So that's a model that we have not started to build yet. But in that case, we'll actually be looking for socioeconomic indicators that would put somebody at risk of, as opposed to looking at particular outcomes. So in that case, we would be looking across the public health literature, across all of the discussion around the kinds of outcomes that are being discussed, including the 3 that you just mentioned, and trying to look at, can we link some of those outcomes to individual level risk variables, and then tie those variables into the census data. So that way, again, for a preventative approach, which of course will be of great interest to public health professionals, we can identify particular areas where we want, geographic areas, where we would want to think about how should we target these areas that we see are quite at risk for residents experiencing high rates of all of the kinds of outcomes you just discussed.
And housing might be one more thing you would want to look at. I just published a housing and COVID paper, and housing type and density are totally related to all of those other things.
They're actually in there. So one of the variables that's going to be incorporated in all the models is actually something called the Vandix, which is tested and created in Vancouver. It's the Vancouver Vulnerability Index. And there are 2 or 3 measures of housing in that vulnerability index, including home ownership. We've had a lot of conversations around density in housing as well. So. Thanks.
Excellent. Thank you very much, Valerie. Fantastic. Looking forward to seeing more from you and your colleagues on the study. We are now at the close of the session 6, Other Impacts. We are going to be moving right into the session 6 breakout with me continuing as chair. Please do not leave. You don't need to go to another link. It's staying in the same
So hello, everyone who's listening. We're going to start at 1:30. So just hang in there. And thanks for joining. Our numbers are climbing. The temperature is rising. The lunches are getting digested or ingested, perhaps. Oh, Kat, my universal atomic clock, courtesy of Apple, tells me it's time to begin. Okay, let's begin. Good afternoon, everyone. This is Peter Berman again, Director of the School of Population and Public Health at UBC, and with my co-chair for this, Tanya Bubala from SFU, for this BC COVID-19 Research and Collaboration Symposium, Public Health, Populations, Health Services, and Impact. Welcome you back to the afternoon events of the second day. We have spent a full day and a half almost entirely focused on British Columbia, with a few forays into other parts of Canada and an occasional mention of other parts of the world. And now we're going to really sharply switch gears and give the floor to many of our colleagues who are taking the research competencies and engagements of our institutions in British Columbia into exploring issues around COVID-19 in the rest of the world under the broad title of global health. There's hardly been a better example in my lifetime of a global health problem than this one, since almost every country and territory of the world has been affected in a very short period of time. So it certainly is global. And there are many, many important issues, and we'll get a bit of a flavor for that. So we've got 8 presentations and 90 minutes, 10 minutes each, and everyone will get gold stars for saving a minute or two as we go along. We'll try to offer a chance for 1 or 2 questions after each presentation, which can be put on the chat, or it's possible to raise hands. I would prefer if we use the chat if we can, because it's easier to just reduce the transaction time to connect and disconnect people and so on. Our first speaker today is Kelly Lee. Kelly, are you there?
I am here.
Okay, great. And I believe all the speakers have been given the chance to share screen if they are so inclined to do any kind of presentation. So go ahead, Kelly, over to you.
Okay, I am going to share my screen now. Hopefully you can all see that.
We can see it, great.
Excellent. Right, well, thank you, Peter and Tanya, for the opportunity to share our project with this great audience. I want to begin by acknowledging that I'm giving this presentation on the unceded and stolen traditional Coast Salish lands. And I also want to begin by saying that our take on global was very much including Canada and BC. BC is a very globalized province. Canada is a globalized country. So this is not about health out there somewhere, largely in low and middle income countries. This is also about Canadian health. So with that, I want to present this project, which is about travel restrictions and cross-border measures, which is very much, I think, on people's minds at the moment regarding COVID-19. Here's our project team. We call ourselves the Pandemics and Borders Project. It's a lot easier to say than our CIHR title. We are collaborating with 4 universities and a number of knowledge users, and I won't go through them, but it's a great group, and we were thrown together very quickly, as a lot of groups are, and seem to be making good progress. The starting point for our project is the concept of governance, and governance to us means the rules and processes by which an organization or any society collectively steers itself towards an agreed goal. And we know that in previous public health emergencies, governance is incredibly important. If you have good governance, good global governance, you will have effective response. It's the basis by which collective action occurs. So when you have an outbreak, what you don't want, and what I think we're seeing, is individual action as opposed to collective action. So that's really our starting point for this project. At the global level, what we have is something called the International Health Regulations, which is an international treaty that is supposed to bring together countries to coordinate together in terms of responding to an event such as COVID-19. There are basic principles involved on how countries should behave and how WHO should act accordingly. And what we found is that there's real questions about how effective the IHR has been, whether countries have complied with it, and so on. So what our project's doing is really looking specifically at cross-border measures, looking at how what countries have adopted what measures, when, and how. We want to look at the evidence of how effective these measures are. We want to dig in and conduct some case studies of decision-making at national level on why these measures were adopted. And finally, the real endpoint is to support better decision-making, more effective decision-making around the use of these sorts of measures. We're a quarter of the way through, so we still have very provisional findings, but what we've done is start to compile this massive data set looking at every measure that's been adopted by every country. And it's a pretty tall order, but we're making good progress. We've started to analyze some of this data in terms of what measures have been adopted. And this is data between January and March of this year. So still there's quite a lot to go yet. But what you can see are the different types of measures that have been adopted. And there's a lot of different ones. And which ones are the most popular among countries. So very impressionistic denial of entry initially in the first few months was the most popular measure adopted. The other thing we're doing is looking at the timing. So this graph just really shows the red point where the public health emergency was declared and when the pandemic was declared. And perhaps not surprisingly, what you'll see is a lot of measures adopted after those 2 points in dates. But there's still a lot of measures being adopted along the way as we go along. So what are we learning from this so far? We're still analyzing, crunching the information that we're collecting. The first thing I think is that we need to extend our focus beyond just these at the border measures. A lot of people talk about slamming borders shut, closing borders, and so on. It's actually a much more complicated picture than that. What we have to look at are pre-border, at the border, and within the border measures that actually work together or in conflict with each other. And it's this whole basket of measures that we need to manage when we're thinking about borders, not just, for example, not allowing people in, restricting travel. We have to think about how we actually combine a number of these measures together or not. And so it's actually more effective to think about border management as a tap. So it's not about closing a door, but it's really about opening or closing a tap. And then what kind of, how much do we open and close the tap, but then how we actually filter as we're using the tap. And all of this, just to say though, is that if a vaccine comes along, this is all going to be a very different picture. This is a situation where there is no vaccine at the moment. Okay, and then I guess the other thing we have to talk about in our project eventually is these lifting of all these different measures. So imposing them is one thing. How do we actually safely, relatively safely lift them once they're imposed? And lots of people are already trying to do this, talking about travel bubbles, corridors, bridges, and so on. Well, bubbles are popping all over the place. Corridors are collapsing. It really does point to the need for a coordinated approach. And as I said previously, it's about looking at the whole range of measures at different points of travel. It's about looking at different ports of entry, because we often just look at air travel, and when we need to look at land, air, and sea together. We have to look at source and destination countries and the relative risks posed for those countries, and so on. So there's lots and lots of coordination needed than we have at the moment. So I'm racing through this, but I just wanted to give you a flavor really of the kind of work that we're doing. We are slowly getting up to speed in terms of social media and a web presence. So hopefully we'll be able to give you more information as we go along. But that's it from me. Thanks.
Great. Thanks, Kelly. That was so super efficient. Very interesting project. You've earned at least one question. Is there any one question coming forward? I don't see any right now. Okay, well, we'll give the opportunity later. Hopefully there'll be some time up. Are you able to evaluate the extent to which measures are enforced, loopholes that undermine their absolute implementation?
Very good question. And that is one of the big issues is that you can impose all sorts of things, but if you haven't followed it up with things like compliance, contact tracing and so on, it really is ineffective. So we are definitely looking at that.
Great. Thank you so much, Kelly. Really interesting project. Our next speaker is Heidi Tworek from the Department of History and the School of Public Policy and Global Affairs at UBC. Heidi.
Thanks so much, Peter, and thank you to you and to Tanya for putting all of this together. I'm very grateful to be here. I'm now just going to share my screen with all of you. Okay, so this is a project that seeks to understand the role of communications, particularly within democracies during COVID-19. I've put here a list of the people who are working on this because we're also working in a whole host of original languages, as I will explain. But we also have collaborators, including Travis Solway, who's at SFU, and Eve Tabergian, who's a political scientist at UBC. So on April 23rd, many of you may have read this, Bill Gates wrote a very long note about how he thought that we were going to deal with COVID-19. Something that stood out to me as someone who works on communications in all its realms is that there was only one sentence Gates devoted to communications, and it was this: it will take a lot of good communications so that people understand what the risks are and feel comfortable going back to work or school. But this quotation obviously raises a whole host of questions. They include, why is communications only about going back, recovering from a pandemic? Why do people like Gates not see communications as integral to pandemic management from the very beginning? And what on earth did he mean by good communications? So some of the things that we seek to do in this project are to consider communications as a crucial non-pharmaceutical intervention, that communications in many forms can actually help to increase compliance, can help to, in the long run, improve people's mental health, and so on and so forth. But what we also see and think about in this project is, how does communications around the pandemic intersect with a whole host of other existing crises that we see in democracies? A lot of people have talked about this pandemic as an accelerator of, for example, inequality and so on and so forth, but it's also potentially, if we're not careful, an accelerator of many of the troubles that we see within democracy itself. Populism, the erosion of local journalism, and things that we've already been seeing like anti-vaxxer activism on social media. So what we're trying to do in this project is, by looking at how a whole host of countries and jurisdictions have responded to and communicated around COVID-19 as democracies, we're trying to think about, what does it mean to communicate democratically during a pandemic? Not just to communicate, not just as a top-down intervention, but what does it mean to do that within a democracy? So to do that, we've done a big comparative analysis. The entire team has looked at sources in the original languages from all of these places, places that tended to respond well in terms of communication, having things that were clear, consistent, compassionate, and that accorded to the 5 principles that we've developed to think around how you might do successful democratic health communications. So we looked at South Korea, Taiwan, Germany, New Zealand, Canada, Sweden, Denmark, Norway, and Senegal. We also wanted to look at a couple of provinces within Canada, obviously British Columbia and Ontario. So you can see that there's a whole range of countries that we're looking at. They have very different healthcare systems. Some of them are more centralized. Some of them are quite federal. Some have reformed quite dramatically in terms of how they deal with communications since SARS and MERS, particularly Taiwan and South Korea. So we also, where appropriate, have compared with places that have done, we would say, a fairly poor job in communicating, including the United States and the United Kingdom. So what we did was we had a standard questionnaire to look at how communications happened, who was doing the communication, how was it received, and so on and so forth, to pull out what we saw as some best practices from these different 11 jurisdictions. So this is really, in many ways, an intervention in trying to show communications as a crucial non-pharmaceutical intervention, but it also gives us insights into how these countries really governed during the pandemic. So what I'm going to do now is just give you a sense of the 5 broad principles that we've pulled out, that we then illustrate with a bunch of examples in a report that's coming out on September 15th. So one of the things that we know from other papers is that the rapidity of how we responded to the pandemic had quite strong effects on how well the pandemic was contained. And that also applied to communications guidelines as well. But one of the things that we found is it wasn't just the speed, there were other principles behind the public health communications within these democracies that worked well. So these are the 5 rapid principles that we've developed and we'll put out in this report with lots of detailed examples. The first that we suggest is that at times it can be better to rely on autonomy, not orders. It doesn't mean that enforcement is unnecessary, but it does mean that autonomy and giving individuals within parameters or businesses within parameters the chance to exercise some control and communicating they have a certain amount of control can prove very beneficial. We've seen that within the way that Bonnie Henry has framed this, and we're now seeing some conflict in a way between how Bonnie Henry is framing this versus public safety officials like Mike Farnsworth who want to bring in greater enforcement. But we found that some reliance on autonomy and communicating that can help individuals to feel more under control. And the second is our advice to attend to values, emotions, and stories, not just facts. We've seen that ranging from instituting gratitude as something that is talked about when you communicate with the population, acknowledging emotions, whether they are negative or positive, and providing specific individual stories that help people to see themselves in those who are being talked about. In Senegal, for example, they would post individual stories on official government Facebook pages. The third thing that we suggest is that you need to pull in citizens and civil society. So rather than seeing communications about health as something that's solely top down that comes from officials, that instead citizens and civil society are given a key role in framing how they want to communicate. To use another example from Senegal, one of the successful things they did was from the start to bring in religious leaders, particularly Muslim leaders, who would show themselves washing their hands and communicating in ways that made sense, so that these figures of authority helped to increase uptake of the various guidelines the government was pulling out. And the fourth thing that we found was that institutionalizing communications was also tremendously critical. In South Korea, after MERS, there was a massive reorganization of how their CDCs functioned. One of the things that was done was create an Office of Communications that then would specifically communicate around infectious diseases. And so the minute that COVID-19 came along, there was already an institution that knew what its job was and could move very, very swiftly. So it helps to give some weight to communications. It's going to go beyond the one sentence of Bill Gates if you have an office that is dedicated to this, to keeping up with the latest research and so on. And the fifth thing that we advise is to think about how you can describe the pandemic democratically. As I mentioned before, political scientists and others are deeply concerned about the state of democracy. If we are not careful in this pandemic, democracy will find itself even more under threat, as we've seen in various authoritarian leaning regimes that have used this pandemic as an excuse to crack down further on civil liberties, not just for a short period of time during the pandemic, but in a more long-term framework. So we suggest, for example, avoiding the use of military metaphors. We found in places like New Zealand, those metaphors were consistently and consciously avoided in favor of things that were pro-social, describing the community, and so on and so forth. So the approach that we're taking in this project is probably quite different from the other projects you've heard around COVID-19, which have mostly focused on the problem of what Tedros is calling the infodemic. So Dr. Tedros wasn't the first person to coin this term, but it's certainly become much more prevalent over the course of the last 6 months, as we have seen evidence of huge amounts of health misinformation, but also all sorts of disinformation around figures like Bill Gates, like you can see here, circulating around the internet. We have a huge amount of evidence now that this kind of infodemic does have real world consequences. So one study has found that nearly 800 people have died after following advice that they could find on social media, or advice, we might say. But what we're arguing here is that while it's incredibly important to try and deal with what we might call its negative information, there's also all sorts of constructive roles for public health officials, government officials, and citizens and civil society to put out reliable information, to communicate about science and about health in ways that diverse populations can understand. And we suggest these principles and give examples in our report about how you can actually go about doing that. So let me just wrap up with a few conclusions. One thing that we have found is the massive importance of learning from other democracies. We couldn't have put this report together without, for example, including places like Senegal, which have a tremendous amount to teach, British Columbia, Canadians, the United States, and so on and so forth. The second thing is that this is a deeply interdisciplinary project. I'm both a historian and I work in public policy, but this includes epidemiology, political science, communications, anthropology, and so on and so forth. And then finally, we found that you just can't think about communications as something that's top down. You come up with something, you go to a press conference and you throw it out there. There's so much more to it. We can think about it as the 6 C's: clear, consistent, compassionate, commensurate, constructive, and contextual communications that are alive to the context in which they are being put out, that includes citizens and a diverse civil society in how we talk about and think about this pandemic, in the hope that we can emerge with democracies strengthened and not democracies weakened. Thank you so much.
Great, Heidi. Thank you so much. One question that has popped up is, how about concerns about the politicization of communication?
Oh, it's a great question. So one of the things that we look at is what we call the division of labor as to who is actually communicating. And we find here that BC is actually an outlier, because in many other places, like for example, New Zealand, we see a division of labor where the Director General of Health will talk about scientific facts and the politician will talk about the meaning of the pandemic. The same is true in South Korea as well, where, for example, President Moon talked about how this can be a democracy strengthening exercise. For example, in South Korea, they actually had a vote during the pandemic and had quite a high turnout. And it was the political figures who gave democratic meaning, but the scientists who actually provided the scientific facts. So BC is an outlier in that Bonnie Henry is often doing both. So that can certainly be a choice, but the place where it tends to not work very well is when the politicians are doing everything. So that's certainly something we find to be very important.
Great, thank you, Heidi. Okay, let's turn to our next speaker, Susan Erickson, a professor at SFU. Susan, are you there with us?
Peter, I am here. Can you hear me okay?
What a nice view. Yes, we hear you fine.
But I seem to have disappeared myself, and I've been trying to find myself again, and I haven't been able to do that. So the options are I can proceed, or we can you can give me a little bit of time to figure it out, maybe come in again.
Okay, if you would prefer that, do you have a presentation that you've not been able to get to find?
Presentation, can you see that?
Yeah, it's working. Why don't you go ahead?
Let's just go ahead with that then.
Yep.
So I'm a medical anthropologist, a professor of global health at SFU in the Faculty of Health Sciences, and I've been following political economies of global health for several years now, with a particular focus on the financialization of global health. And I've just finished up a course, so this is more than you need to pay attention to. I want to bring your attention to some of the changes in global financing, global health financing, and health financing more generally speaking. If we think of Plan A as that turn towards the nation state provisioning and management of healthcare, and we see attempts to actually bring about systems that will provide healthcare for most of the people most of the time. What we've now moved to, and there's a lot in here which obviously I won't be talking about, what we've now moved to though, and where I will focus, is on this tension between the push towards universal health coverage, but it's both an and a versus, the increasing financialization of global health. And I pay particular attention to what's called innovative financing. So I'll just give 2 examples here very briefly. There is so much to talk about this. These are very complex systems, but let me just give you a quick overview of the kinds of things that I'm tracking and teaching and actually doing research on. So in the first case study, this is just an example of the way that hedge funds and private money have made their ways into public health, and the kinds of things, the way that business metrics have really taken up more and more space in terms of organizing particular interests in global health. So if we look at a US biotech company called Vaxart, it has recently gotten some attention because it became the focus of US Operation Warp Speed. That is a US policy intended to put a lot of money to accelerate vaccine production. So this biotech company, which has never brought a vaccine to the public before, it only has about 15 employees. It has its largest shareholder is a hedge fund, Armistice Capital. And before the pandemic, Armistice Capital bought up about 2/3 of Vaxart's shares. And the founder of Armistice Capital actually joined Vaxart's board. Now, a lot of these things aren't legislated, the special interests aren't tracked. And even when there's a whistleblower alert about some of these things, there's always the question of enforcement. So the founder ended up buying shares at about 30 cents a share. So January, before the pandemic really takes hold, we see Vaxart, because a lot of vaccine producing companies, actually their share prices increased. By April, it increased quite a bit. And by June, it had increased from 30 cents a share in 2019 to about $14 a share. What this meant for Armistice Capital is that June, 3 days after this $14 share price hit, Armistice Capital actually ended up just selling the vast majority of its shares and made $197 million without the vaccine being produced. So my point here is to just really send out a kind of alert to public health folks that the kind of good and well-intentioned initiatives that people assume that public health efforts and public health monies, that we might need to interrogate that and look at that a little bit more critically. I'll turn now to a second case study, and that is work that I've been working on since 2016, and that is looking at the way that insurance is being used to actually create what they're calling pandemic bonds. And I've wrote about this in a much longer article in Medicine, Anthropology, and Theory, an article called Global Health Futures, Reckoning with a Pandemic Bond. And the details of this are, again, quite complex. I won't go into it, but just know that this is a pool that the World Bank has put together, a $450 million pot in anticipation of a pandemic coming. And perhaps the idea was that the bond would last for 3 years, that investors would put up their money. And if there was no pandemic during that 3-year period, then the investors would make a fair bit of money. Now, what we saw with coronavirus is, in fact, there were many instances of Ebola where people thought that the pandemic bond would in fact trigger. It did not trigger for the cases of Ebola in the Congo, but we did see that with coronavirus, which is one of the viruses that's covered by the bond, it did in fact trigger after 2,500 people died. And so this is, again, just to give you another quick example of how it is that people are making money on the pandemic. There's a lot of details here, but if you want to get a sense of how much money people could potentially make, there were several pandemic bond investors who invested $50 million in this bond. And then what that meant was that at the end of the 3-year period, the $50 million investment would actually end up resulting in a $7.4 million return. Lots of details here that I don't have time to get into, but just want to introduce this idea to you. There was some payout in the case of the coronavirus. The payout actually came out, this was issued in April, but the payout was to IDA countries, and the minimum was $1 million, the maximum was $15 million that you could apply for, and $195 million of the $450 million pool was in fact ultimately distributed. So something a bit different there for your attention, but just wanted to give you a sense, perhaps maybe I did nothing more than just broaden the kinds of things that global health researchers in BC are looking at.
That's great. Thank you very much, Susan. Also time for a question if there is one. I will just make a little plug that we're hoping to invite for a seminar this fall the person at the World Bank who's been running this pandemic bond enterprise, who does tell me that the investors have actually lost quite a bit of money now because of it. So anyway, any other questions for Susan? Okay, let's move on. We're right on time. Perfect. Our next speaker is Mike Law, professor at SPPH at UBC. Mike, can you, Susan, could you unshare your screen? And Mike, you can take over.
Yeah, can you see that, Peter?
Got it.
Perfect. So hi, everyone. Thanks very much, Peter and Tanya, for the invitation to join you today and to present some of the work that I'm doing with colleagues to respond to COVID-19 in a number of countries. So essentially today I'm going to take you on a quick tour of a CHR-funded project that I'm engaged with colleagues from 7 countries and including American collaborators as well. So just to give you a brief introduction, so routine health data, for those of you who aren't familiar with the term, is data that's collected in the sort of everyday function of the health system. So in a lot of countries, we've over the past decade, we've seen really rapid increase in the number of electronic data sets that have become available and are being assembled in countries across the globe. And the picture here is of very non-electronic records, but what you see in a lot of countries is these formerly paper records being turned into digital records. These can come from a number of places. So researchers in Canada will be used to the insurance billing data sets that provinces will use. In a lot of countries, DHS2 based systems are often used. So this is a software package that a number of countries use, and it's the District Health Information System. And so these will be facility level statistics on health system utilization and health presentation. So whether number of deliveries or things like that. The advantages of using routine data are many, but they're longitudinal, rapid, and low cost. And we can get into a discussion of their disadvantages if you like. Just to give you a sense, we've used these before in research that I've been part of as part of my team. This is a chart from a project that we did in the Democratic Republic of the Congo during the first Ebola virus disease outbreak and the current outbreak. So this is in 2018. And you can see what the DRC did is they introduced a free care policy in the middle of 2018. So that's the second dotted line. And you can see in the red and blue areas, which are the areas that had that free care policy put into place, the total visit rate in those regions to health facilities went up quite dramatically as a result. So there was some concern that people wouldn't present to health facilities, but this free care policy seems to have done a very good job of eliminating that. So that's one example of a project. So in this case, we went to CHR with 2 questions about the use of routine data in response to COVID-19. And so the 2 research questions that we went in with were, first was syndromic surveillance. So in each of the 7 countries, we were going to look at what local and regional areas are showing signs of patients showing up with COVID-19 associated symptoms, and whether we could use those as indicators that would precede testing in a lot of areas, particularly if testing is constrained. And then the second question that we were looking at is using these same data to look at health systems utilization. So in the 7 countries we're working in, did we see changes in the use of both COVID-related and non-COVID-related health services as a result? Because you wouldn't want to see, say, drops in immunization or facility delivery as a result, because people would fear going to these health centers. In terms of our team, we've got 7 countries. So Haiti, Mexico, Lesotho, Rwanda, Liberia, Sierra Leone, and Malawi are all part of this through links with the Partners in Health associated sites in each of those countries. So my co-PI, Bethany Het-Gauthier at Harvard Medical School, and I have been working together in Rwanda since the early 2010s, and we've managed to include co-PIs from all of these 7 countries in collecting and using this data. So what we're collecting in those countries is a little bit different in each country, but largely similar across the board. So you'll see here that in one country, Haiti, we're using a surveillance system that is based on weekly data collected from health facilities. But the majority of these countries, Lesotho, Liberia, Malawi, and Sierra Leone, and as well Rwanda, are all based on DHS2. So these are statistics that are collected at the facilities every month by someone who's dedicated to collecting them, and then sent to a central database. Rwanda says HMIS, but that's their technical name for their DHS2 system. And then in Mexico, we're using EMR data from the facilities that Partners in Health serves in that country. And you'll see here the data availability is one of the most amazing features of using routine data. Essentially, by the middle of every month, we can get last month's statistics. So in comparison to collecting things in a fashion like through a survey or something of that sort, these are incredibly fast and incredibly up to date. And then what we're doing is collecting the data from all of those sites. So you'll see on the left side here, we have the sites sending all of these count data aggregated by facility and date, essentially by the middle of each month. We have a data processing pipeline set up where those data are collected, cleaned, and we do statistical modeling and produce data visualizations via graphs and maps in 2 to 3 days. And then we have monthly calls with all of the sites to discuss what we're finding and what we're seeing as we proceed. And to give you a sense for some of the data, we're right into this now in terms of the syndromic surveillance, and we're starting to pull data out on the health services utilization part of things. But just to give you an example, here's some of the facilities in Lesotho that we're tracking as part of this project. And you'll see here that when the pandemic hits in early 2020, you start to see pretty precipitous drops in the monthly counts of outpatients. So the light purple line is what we predict we would have seen based on previous year's utilization, and then the black is what we actually see. And you can see that things drop off fairly quickly when the pandemic hits. So as we develop this project and continue to assemble the data, we're going to do more of these types of analyses where we use time series methods to predict what we would have seen had things not changed due to the pandemic. And as well, we'll engage in more formal interrupted time series analyses like the one I showed you earlier from the DRC. So then finally, in terms of the deliverables, just to give everyone a sense for what the outcomes of our project are. We're producing monthly reports for sites. So these will go to the Partners in Health facilities in each of those countries, as well as to national level decision makers like ministries of health. We're going to produce a website with code in order to provide the basis for others to do this sort of syndromic surveillance and assessment of changes in health services utilization. So everything is being coded in open source platforms like R. So we hope that others will be able to utilize that website use the code to do these things on their own end. We're going to have a training course put together by the folks at HMS that is going to go through essentially doing a syndromic surveillance exercise with country's own data. And we're hoping for more traditional academic publications out of this, some of which will be methods oriented in nature, and others will be the impact of the outbreak on various, the use of various types of healthcare services. So that's all I have prepared for today. Happy to take any questions, and thanks very much.
Great, Mike. Thank you very much. And also very efficient presentation. I'll look for questions, but let me start with one. This is a very interesting area of work, of course, and there have been some both provocative and as well as disturbing papers written about the potential impact of drop-off of other kinds of care, perhaps much greater health impact than COVID itself. What is your group thinking about how to use this information for remedial measures? What are people thinking about? What can be done about this?
It's a great question. So I think, a lot of that will be specific to the context in which it takes place. So, for example, the work on the free care policy that we did in the DRC suggested that co-payments were a big factor in dissuading people from seeking services in that country. So, in that case, the policy change of giving people free access was an obvious way to try and alleviate that. So in a lot of these places, it's going to be specific to the context, and we're not at the point yet where we've seen these things and been able to assess what what policies or interventions we've seen in various countries that might be related to that.
Okay, great.
I wish I had a better answer for you.
Thank you. Well, we'll come back to talk about this when we hear from Annalee and Jerry about health worker safety, because one of the interesting aspects of that is making health workers safe may also make people perceive health facilities as being safe as well. So interesting. Anyway, thank you very much. We're right on time. And our next speaker is me. So I am going to share my screen. And I hope you can all see my slide now. And I'd like to share some information about a research program that a group of us at UBC are engaged on to look at the role of politics, organization, and governance in the governmental response to COVID-19. We use this acronym IOGP, Institutional, Organizational, Governance, and Political Factors. And broadly, we come with these kinds of definitions. Institutional refers to the higher level formal and informal rules of the game. This is kind of bringing an institutional economics approach to this. Organizational is more about the organizational and structural and functional design of the public health and also the other health system and related elements in national or jurisdictional areas. Governance, we're focusing more on how the parts of this design relate to each other and what are the processes through things do or do not get done. So rather than the more common approach of creating an index of good or better or worse governance, it's more about a process analysis. And for the political category, we're interested very much in how politicians and the political processes support or constrain effective public action. Now, why and how do IOGP factors matter? I think one interesting example of this is that in 2019, a global health security index was created. Before the pandemic, it scored 195 countries around the world on pandemic preparedness. The US and the UK ranked #1 and #2. And the index overall does pretty poorly in predicting effective response to COVID-19. Why is that? Does IOGP explain some of this discrepancy? They looked at an objective set of measures on preparedness, and we find that it doesn't really predict the actual response very well. The hypotheses are that IOGP is a key determinant of how knowledge is produced and used to guide government action, and how well directions for action are implemented by organizations and also responded to by citizens. So it affects both the supply side, what is accepted as known and by whom, and this links to Heidi's work on communications, and what is done with the knowledge, and also the demand side, the trust and confidence of citizens in government direction and their compliance. And it affects three important areas of government action, which we've been discussing the last 2 days: the public health response, that is the response more specifically focused on the prevention and mitigation of the spread of disease, the clinical preparedness and treatment response, what do you do with the population who become ill and severely ill, and also the non-health actions. And we've seen these three domains are all impacted on by the way IOGP factors take place in different jurisdictions. Here's a simple graphic which just tells you a little bit of why this might be an interesting story. At the top, the disease progression in Canada, in the middle, British Columbia, and on the bottom, Ontario. The gray bars essentially represent the period when almost all the non-pharmaceutical intervention measures were put in place in Canada. And you can see, comparing British Columbia and Ontario, very different patterns of the development of the epidemic curve. Raises the question, why these differences? Some of it might be environmental and contextual factors, but is some of this difference due to these IOGP factors? So some things that mattered in British Columbia, we've talked about the strong legislative powers in Canada for the provincial health officer, strongest in Canada, according to a recent analysis. A highly capable provincial health officer, political leadership that deferred to science and expert knowledge, and the relative lack of disruption by opposition politicians, which we haven't seen so much in some other jurisdictions, a single payer medical care system, which allowed rapid action to be taken, and a high degree of social solidarity in the population, and early action and time to mobilize these in the early stages of the epidemic. This is a logic model for our research, and I just want to point out that we are recognizing that there are important contextual factors, but the politics and institutions, the organizational actors, and the governance, and then moving down more towards intervention, the effectiveness of intervention, the timing of intervention, and ultimately the outcomes. The red items down here highlight the fact that we really do lack data on the organizational design of the health system response, as well as on the governance processes. And this is the area that we're trying to focus on in terms of the research that we're developing. Our research plan right now is we have a multidisciplinary research team at UBC, largely linking together researchers at the School of Population and Public Health and the School of Public Policy and Global Affairs. We're developing measures and instruments for these IOGP factors, and particularly for the organizational and governance factors, because there are quite a number of political and institutional indicators and variables that are measured on a regular basis for many jurisdictions. We're developing an early application of this approach through an in-depth British Columbia case study. We're planning for an online symposium with global collaborators to review and strengthen these methods. In other words, to share our efforts at methods development and get feedback from global colleagues as to their relevance and usefulness in their own contexts. We hope to develop a series of country case studies, again, focusing on these IOGP measures, relying primarily on secondary data and media, and then bringing together the widely available data on interventions and outcomes that are being reported quite regularly for almost all countries around the world and many subnational jurisdictions. We'll be opportunistic about this in selecting countries, but also hope to do some more purposeful selection of countries for these case studies. And we've been developing collaborative research with in-country partners, initially with Peru, India, China, and Ethiopia, but also exploring other opportunities. The impact of this work, I think it's important to note that this is probably work that's most useful not for the next 3 months or 6 months, but probably for the future responses to public health crises like COVID-19, because IOGP factors don't change very rapidly. So this is really about developing the organizational models, the legislative and regulatory models, and documenting better practices that leaders could try to adopt in the future. And so this would include better legal and regulatory frameworks, advocating for more and better investments in human resource capacities and other inputs for the public health response, replicating better organizational models for public health functions, learning from experience on how to mobilize non-government capacities in line with public policies, and initial design of better capacities, especially in many emerging economies where they are, in fact, in the process of developing these capacities going forward. So that's from me, and I will stop my slideshow and see if there are any questions in the minute I left myself. Tanya has a comment. Let's see, I have to go down to my questions. Okay, I don't see any specific questions, and I'm not going to ask myself any questions. So let's go, let's see if I can find my agenda again. End of slideshow, click to exit. Did I exit my slideshow? Can someone tell me?
Yes, you did.
I did, okay. Thanks, that's really multitasking. Okay, our next speakers are Annalee Yassi and Jerry Spiegel from SPPH at UBC. So turning it over to you. I see I did get a question at the end, but I'll Annalee, Jerry, are you there?
We didn't unmute. Okay, sorry. Do you have our screen on? Is our screen on?
Not yet, not yet.
Oh, let me see how we could. 1 second. How about
There,
now?
got it now.
Okay.
Okay, great. And we'll be doing this together as we do many things. And we'd like to begin just by sending huge thanks and appreciation to the organizers of the symposium and this session for what a wonderful start to the new academic year, and as well to have this get together on such an important area of focus. Now, we talked a lot about context in your presentation, Peter, and we'd like to really focus on the context of working environments and do this in resource challenged settings, as Mike was speaking in terms of approaches in those kinds of settings. And this is in South Africa. That's part of a study that's looking at contextualized global occupational health in Canada and South Africa. We were recently funded by IDRC through the CIHR Rapid Response Competition, but this really continues a collaboration we've had going since 2006 through the network of WHO collaborating centers. And it shows the importance of developing strong partnerships to extend this kind of work. Through this work, some of which we'll describe, we have extended for this competition to 2 health authorities, the Vancouver Coastal Health in Canada, but notably the Gauteng Department of Health, which is the largest province in South Africa. The reason why the South Africans were interested in developing this partnership and invited us in was because of their particular needs that they saw. If you look at TB incidents in the country, you see a rate of 100 times greater. And in 2006, it was even higher. We see with COVID-19, we see that the situation for active cases in South Africa has been worsening. And although the death rates are similar, if you see the active cases are really growing at a huge rate, creating tremendous burdens on their health system, which is already strained. And in Gauteng province, which is our main partner for the case study we'll describe, there's 79,000 total healthcare workers. There's been 45 deaths and over 5,000 positive healthcare worker COVID cases in this year.
So the rationale for our study is that healthcare workers worldwide are at increased risk of occupational infectious diseases. We've known that for a long time, not only from TB, but SARS and Ebola and flu and everything else. But different jurisdictions take different approaches with respect to the PPE recommendations, contact tracing, testing, return to work policies. And policymakers want to know what works best to protect healthcare workers, in what context, using what mechanisms to achieve what outcomes. In other words, this fits very well into the project that Peter just talked about, because looking at what are these organizational and system factors that influence the infection of healthcare workers, especially in low and middle income countries. In addition to the infectious disease hazards that face healthcare workers, from airborne and droplet spread and contact spread, that there's a myriad of other workplace factors that interact with it. That unlike the situation in Canada, for example, where we have lifting devices, people that in other countries that's why long-term care is such a hotbed of care, because they're very, very close associations. People work long hours. There's violence from angry patients. There's mental health concerns, including stigma and the concern from healthcare workers taking illness home, as well as various other occupational health issues. So over this last 15 years, we've been working with our colleagues to train people in audit tools and improving knowledge hazards. We've used all sorts of various study designs, including a cluster randomized controlled trial in 28 hospitals. So this is a very mature partnership that have gone into many different areas, but also very closely working with the WHO and the International Labour Organization and using their tools. We've developed training programs in the past to build local capacity to participate in these kind of projects. And it's, obviously really key for us to constantly keep in mind the history and socioeconomic and political context, because the legacy of apartheid, as well as economic globalization, is just very clear in every aspect of what we see on the ground. And we need to be cognizant of course, the complexities. Every organization has its own organizational culture and its own quirks, and the complexities of respecting local knowledge and in each setting. We've had the advantage, because we've been working in a multi-scalar way with international, national, provincial, and facility level collaboration all the way along. So the particular project that we've gotten funded for is multi-component. It involves in-depth case studies using interviews, document reviews, putting together the qualitative analysis to really understand the health system aspects of all of this. We also have another sub-study that's focusing specifically on the mental health of health workers. And we've embedded this in, since we're very active, both our South African colleagues and ourselves, in our WHO network of what's going on comparatively across 161 countries. The centerpiece, though, is a case control study to look at why healthcare workers get sick. Is it occupational? Is it community? Is it the transportation? Is it lack of PPE, lack of awareness, and so on? So back to Jerry.
So in taking at this study, and we're doing this work in South Africa, along with some other work in Vancouver coastal area, but we wanted to look at very much at the contextual factors, as you had addressed, Peter, but as also Annalie was explaining. What are the conditions that enable better policies once we look at the mechanisms and their impact? So we're trying to have, through the case studies, a good appreciation of what exactly is transpiring, answering perhaps that challenge of having a better organizational documentation so that we could link it to other determinants or factors that are associated. And we want to be looking at specific policies and interventions that we identify to see what their effect has been in relation to these outcomes, especially through the case control study, but also through the more qualitative case study. And look at that in the context of what are the drivers. Now, one of the aspects that we wanted to look at, specifically building on previous work, is the way we're actually using the information that could be generated routinely as we manage this. And if we're really learning as quickly as we can to such a challenge. And the basis for our original partnership was the application of an information system called OASIS. And that's something that our colleagues in South Africa have developed a specific module and code that's capable of producing timely dashboards and reports for the National Health Laboratory Service throughout the country. Now, as I said, this was the original source of the interest that they had to have the adaptation for this information system, which they now actually have the code transferred to them. So they actually manage the system. But it raises the question of systems like this is, do they, especially in such a politicized environment as occupational health, do they function as tools, as weapons by some of the parties who use parts of the information for their own use? Or are they white elephants, as many information systems are? So we're revisiting that 15 years of history in a crisis situation to get a better appreciation of what's a success factor.
So the challenges in this particular research project is, first of all, the fact that the pandemic is rapidly evolving, but also because most of us who are involved in this also have service responsibilities, and it's tough balancing the research elements and the pressures of health services at the same time. The digital divide is still very real internally within the country that hurts a lot of the the mechanisms of what happens within the research. There's research fatigue, as there's lots of research going on, and data sharing issues. And unfortunately, in South Africa, governance and corruption are still very, very much concerns. This was something from just yesterday where the MEC, the equivalent of the minister, was fired for rerouting a huge amount of money that was supposed to go for PPE. So these things are there. But the mitigating measures that we're using, which we were asked to specifically look at, is the research is very much anchored in the service. It's needed for informing the day-to-day activities. So there's engagement in it, because right by the knowledge users are the people involved. We're involving a lot of students as research staff, which will help remove the burden from the key investigators, and trying to collaborate and as much as possible with other studies so we can facilitate data sharing. So to end, I think a lot of you have seen the slide many times before, that if you're coming to help me, you're wasting your time. If you're coming because your liberation's bound up with mine, let's work together. As Peter started with at the very beginning, there's probably no better example of a time where the health needs anywhere are a health need for all of us. So the incentive to work together is extremely strong. So here's just a list of the various collaborators. On the Canada side, we have Vancouver Coastal Health, as well as UBC. And in South Africa, we have University of Cape Town, University of Wits, and the National Institute for Occupational Safety and Health, as well as the Department of Health itself. Thanks.
Great, thank you, Annalie. We could take a question if one is forthcoming. We will have time at the end, the way this is going, for some questions and discussion. Nothing is jumping up on my screen, so I will then make sure we have time at the end. Let's move on. Our last two presentations are going to shift gears somewhat to look more at specific groups of beneficiaries and specific types of outcomes. Julia Smith from SFU is our next presenter. Julia?
Hello.
There you are. Great.
Let me just share my screen. There we go. All right. I'm going to talk about the Gender and COVID project today. And we are implementing this project. I'm working with quite a large international team here. The project's based at SFU and funded initially by CIHR, and then more recently expanded through a grant from the Bill and Melinda Gates Foundation. And we're conducting research in 9 different countries. You can see Canada, Brazil, Nigeria, DRC, Kenya, Bangladesh, China, and Hong Kong. And we're looking at the gendered effects of the response to COVID-19. So this is somewhat different in the sense that we're not looking necessarily at the effects of the virus, but the effects of the response. So the different public health, economic, and social policies that have been implemented and how those have affected people of different genders differently, and either exacerbated or addressed inequities. In doing this, there's a high component of policy analysis, looking for gaps and opportunities to advance gender equity and gender transformation. And we also aim to provide some very concrete guidance and tools to policymakers and decision makers in these countries, as well as globally. So I realize many of this might not be completely new to many of you, but in terms of the rationale for the project, I think it's important to reflect on why a gender-based analysis is necessary when we look at outbreak responses. And many of us know that health crises have very differential impacts on male and female bodies, so on people, and we can see that with lots of different types of health crises. And initially with COVID, we were seeing, very different rates of infection and outcomes on males and females. And that's starting to change and become a bit more confused. And I think that does relate to the fact that health crises are also structured by social and economic and political differences. And that's what this project is really about, is how men and women and non-binary people are affected differently by crises response. Many of us in the project have written about this extensively, specifically as concerns women, and recently published a commentary in Nature kind of outlining this past research. It takes examples from Ebola and Zika that show, for example, with the Ebola outbreak in West Africa, women were not only most negatively affected in terms of their economic opportunities during that outbreak, it took them longer to recover from the outbreak economically. So we have that evidence from the past. We also have evidence that crisis response can exacerbate inequities. And the worst example of this, again, comes from the Ebola outbreak in West Africa, where resources were diverted from maternal and reproductive health services to the outbreak response without consideration of what that would mean. And consequently, maternal mortality in the rate went up 70%, to the point that more women died giving birth than from Ebola during those years. So, there's a strong need to take these sort of issues into account. We recognize that much of this past research has focused on women specifically, and there's a need for a much more complex understanding of the gendered effects and also how gender interacts with other identity factors. And the COVID, outbreak is having very specific social and economic impacts on people of different genders and, again, different identities. And that's something that we're trying to understand and document in order to inform more equitable responses. As I mentioned, we're working across a lot of different geographies, and each team in that geography is implementing the project in slightly different ways that reflect that context, understanding of gender in those contexts. However, we have developed this grounding framework, which is a COVID and gender matrix. And this is a simplified version because the full version has way too many words for a PowerPoint slide. But it's sort of our grounding framework for how we start our analysis, the types of questions we're asking. It reflects the interdisciplinary nature of our team. So our team includes health system scholars, it includes anthropologists, it includes political scientists, economists. And so we're really looking across a range of gendered factors, so access to resources, how gender norms impact people's experience of the response, as well as types of effects or impacts. So everything from health impacts, such as infection, to economic and security impacts. This tool is evolving and continuing to grow. It's also being adopted by other research streams, which is quite exciting to us. So we know people in other parts of the world that are also now using this, and it's being translated into French, Spanish, and Portuguese to facilitate that sort of, widespread analysis. In terms of methods, we have a mixed methods approach. In some countries, we're focusing primarily on the qualitative interviews, so qualitative research. So here in BC, I've done about 25 interviews to date, and I'm doing key informant interviews. Around the world, we also are doing a lot of administrative data analysis, and we're doing surveys, quite extensive mobile phone surveys in 3 countries. It's one of the challenges, and quite honestly say we're experiencing, is wanting to do a very intentional mixed method approach where the qualitative and the quantitative and the different aspects interact and inform each other, but at the same time, trying to respond to a rapidly changing situation and demands for evidence and data now. So that's something we're grappling with. Despite working across very different geographies and contexts, we are already starting to identify some global themes in our initial, very, very initial research outputs. So, the crisis in the care economy, the need for childcare, the impacts of school closure, and how that's, particularly impacting women is something we're seeing in each case, and we're looking at it in more detail in terms of how that interacts with women's health and well-being, as well as economic opportunities. We also recently co-authored a report with UN Women that kind of tries to sketch out some of these themes in terms of impacts on the Sustainable Development Goals. So this is kind of the, where our outputs, we hope, will both be very specific national and local contexts, as well as some global level analysis to understand how this crisis is not just a health crisis, but it's affecting gender equity on a global scale in some very concrete ways. One of the key partnerships of our project is the Gender and COVID Working Group that was kind of grew out of this project from the very beginning. This is a working group that now includes over 400 members around the world, and it's everyone from health professionals to national and global policymakers to academics. We meet once a month and have these epic Zoom calls with multiple, dozens and dozens of people, and have a number of other resources happening. We've hosted forums. We have a Mendeley library. If anyone's interested, I highly encourage you to join. Just yesterday, through our gender working group, we were able to present to Dr. Tedros at the WHO, and he is now committed to including a gender working group within the WHO's response. So we're quite excited about that, to see some, early activity in the policy sphere around incorporating gender-based analysis into the response. And I'll leave it there. Thank you very much.
Great, Julia. Thank you so much. And again, I'm not seeing any hands or questions coming up so far. So I think we will move on to our final speaker, Professor Laura Ackman from Department of Psychology at SFU. Lara?
Oh, hi, thank you. I'm just trying to share my screen here.
Okay.
There we go.
It's come up, and
Perfect.
Please go ahead.
Thank you. So hi, everyone. Thank you for the organizers for putting together this event and so quickly. My name is Lara Ackman, and I'm an associate professor of psychology at Simon Fraser University. My research focuses on the antecedents and consequences of human happiness and well-being, with a particular focus on if, when, why, and how helping others through kind or otherwise helpful behavior can promote our own well-being. So today I'd like to share with you some statistics on how Canadians have been reporting their mental health over the past few months under COVID. And then in light of these data, I'd like to present some results of our recent experimental work investigating whether small acts of prosociality can offer a short-term boost to mental health during the pandemic. So as you might imagine, the past few months have had a negative impact on Canadians' mental health and well-being. Results from a large crowdsourced survey of over 46,000 people conducted in the early months of the pandemic showed a threefold increase in the percentage of Canadians indicating that their mental health is fair or poor compared to 2 years prior. Now, it's worth noting that these data are not probability-based and therefore should be interpreted with some caution. However, they are consistent with recent results from the Canadians from Stats Canada's probabilistic web survey, which suggests that over 50% of Canadians say that their mental health has decreased during the pandemic. Now, these summary statistics mask some important details. In particular, 88% of respondents report at least one anxiety symptom over the past 2 weeks, and 41% of people indicate symptoms that are consistent with moderate to severe levels of anxiety. And importantly, these rates are even higher in some subpopulations. For instance, 64% of youth between the ages of 15 to 24 report symptoms of moderate to severe anxiety. And these findings are not limited to Canada. For instance, earlier this month, the CDC in the United States reported a stark increase in symptoms of anxiety, depression, and suicide ideation, and again, showing gross inequalities of how this is represented across the population, and particularly high rates in vulnerable groups. So with more people experiencing adversity and experts warning that vaccines and pharmaceutical solutions may not be available for some time, researchers have been underscoring the importance of developing novel interventions to protect mental health and well-being. To this end, my colleagues and I have examined the efficacy of one potential strategy, which is helping other people. Why helping behavior? Well, a large and interdisciplinary body of research suggests that people are exceptionally generous creatures. People give of themselves in various ways, including donating their time, their money, their blood, their food, and advice to other people. And while some theories might assume that humans could retract and withdraw these pro-social efforts in the face of adversity or distress, numerous accounts actually suggest that human generosity persists and can sometimes even increase in emergency situations. For instance, data collected in Louisiana in the 3 weeks following Hurricane Katrina documented impromptu emergency support of prosocial behavior from diverse groups like hotel workers, hospitals, and various communities in response to the catastrophe. Moreover, humans not only engage in a wide range of generous action, but they appear to derive emotional benefits from doing so. Over the past decade or so, my colleagues and I have found that helping others through simple, small acts, with as little as spending $5 on another person as opposed to oneself, for instance, can lead to measurable benefits for one's own well-being. Our initial findings were documented here in Canada and in the United States, but we've since conducted surveys and collected data from responses from rich and poor countries around the world, including responses from over 236,000 people sampled through the Gallup World Poll. We've also probed this relationship in toddlers just under the age of 2, and most recently in large pre-registered experiments with a total sample of upwards of 7,000 respondents. In short, we find a robust evidence for the short-term emotional rewards of generosity. And so we questioned whether this finding might persist and be of use during the pandemic. Now, this hypothesis extends clearly from the literature I just described, documenting the emotional benefits of pro-social behavior. However, it did seem plausible that these typical findings might disappear or even reverse in the face of the COVID-19 pandemic, because some have argued that this is the largest collective trauma that most living humans have ever experienced. It seems possible that COVID-19's imminent threat, exceptional spread, and an ever-increasing death toll could significantly change how people empathize with others. And so my colleagues and I conducted 2 large pre-registered experiments to see whether generous behavior, captured here in a form of generous spending money on others as opposed to oneself, can improve mental health, again, during the pandemic. So as I mentioned, we conducted 2 large pre-registered studies. In both cases, participants were recruited for a short study online. The study methods are presented pictorially here, so I'll pull out the main events. The survey began by asking people to report the impact of COVID in their daily lives. It assessed their intrusive thoughts on COVID-19 and asked people to report their baseline levels of affect or emotion. Afterwards, people were randomly assigned to either a personal condition or a pro-social spending condition, in which they received a small sum of money that they could use to purchase an item either for themselves or a needy other. Now, specifically in study 1, participants in the pro-social condition could choose between making a donation to one of 2 real charities, and participants in the personal spending condition, could claim a $1 worth of cash, an equivalent value, for themselves either via Google Pay or Apple Pay. In study 2, we adopted a similarly conceptual design, but here we tried to manipulate whether the items purchased were COVID related or not. So specifically, participants in the personal spending condition could buy either a mask or hand sanitizer for themselves, or in the non-COVID specific condition, either an edible treat or a writing tool like a pen for themselves. Meanwhile, in the pro-social spending condition, people could choose between buying these items in the COVID-specific condition. They could pick between sanitizer and a mask for someone in need, or in the non-COVID condition, a granola bar or a pen for someone in need. Now, after making these spending decisions, people were asked to report their current emotional well-being, complete another COVID thought intrusion task, and complete measures about fear and worry, and finally some individual difference scales. So consistent with the overwhelming majority of our pre-registered predictions, we found that participants randomly assigned to make these small acts of generosity for others with as little as $1 worth reported greater well-being on various indices of mental health and well-being than people who spent the equivalent amount on themselves. Now, these data were quite consistent across studies and emerged regardless of whether the kind act was relevant to the pandemic by giving hygiene supplies or not. These findings suggest that one way to improve short-term mental health is to help others. This strategy stands to provide one low-cost, familiar, and accessible means for boosting well-being during COVID and beyond. In follow-up work, we'd like to examine how receiving these kind acts might help make the recipients feel. So among friends and family, these small gestures could help to facilitate feelings of connection while people practice physical distancing. And because kind acts can be directed towards strangers in one's community, these acts could foster, potentially build new relationships. More broadly, I think these findings reflect the human importance and their capacity for care, and they show that even in some of our most challenging times, helping others can also help ourselves. So thank you. Oops, sorry for that final point popping up there. So thanks for your time. Excuse me, here's a link to the preprint and my email and contact information in case anybody would like to be in touch.
Great, Lara. Thank you so much. A nice note for our final presentation on generosity. I think we can also say that the very great participation we've had in this event has been a good example of that also. Any specific questions? There is a question for Lara. Can you please show slide 2 again, the
Sure.
results of the survey?
Yes, just give me 1 second to reshare my screen and backtrack the results of here you go.
Okay.
If helpful, I can put the link to the survey findings and write up in the chat box.
That would be great, I think. Okay. So I've got 2 questions that have been posed in previously that we could come back to briefly, but I'd like to leave at least a couple of minutes for open questions and comments. One question for Jerry and Annalee. Does your health worker analysis, what does your health worker analysis say about gendered, contextual, and organizational factors, from Julia Smith? In other words, are there gender differences in these contextual and organizational factors in what you've been doing?
Yes, I started answering that in the chat. The vast majority of healthcare workers are female. There's very strong elements or very strong basis to do gender analysis. Also in South Africa, domestic violence has been very much on the rise. Plus there's bullying in the workplace that's come up as being a really big concern, which is gendered as well. So there's many dimensions of it. To be honest, we haven't structured a real project to look at it. We had good vocabulary on it and we did get our grant and a nice little blurb. But if there's someone who wants to join our team to specifically look at the gender-based analysis, there's certainly room for that, and we'd very much welcome that.
That's great. Thanks, Annalee.
Yeah, I have a question, by the way, for Laura, if there isn't a long
Go ahead.
questions which is one of the things that we've been sort of playing around with this whole issue of volunteers versus paying people. In the little sort of service work that I'm doing in Vancouver Coastal, we've had a huge number of people volunteer to help. So we accommodated about 20 volunteers and that were working great and everything was structured wonderfully. But then at a certain point, I began to feel that these people need to make money. These are young people, and felt that it would be better to have fewer of them and pay them, so at least people could be paid for all their wonderful work that's being done in this pandemic. And so the flip side of doing acts of kindness is the potential of taking away other people's jobs and doing that. In other words, these folks should get paid to be doing some of these services especially at a time when jobs are so scarce. So I'd like to know, your thinking on that.
Yeah, so most of that's a really interesting question. I thought you were going in one direction, but it actually ended up somewhere else. I thought I had an answer prepared in it. A lot of the kind acts that we study in my lab tend to be these relatively small, mundane acts. They would rarely take away someone's profession or intrude on that boundary. People are buying coffee for someone in need. And most of the time, I think these are small, everyday, random acts of kindness, and that's what I typically study. And that's kind of a pragmatic result of the fact that, we get grant funding that doesn't allow people to make, huge donations and sums. That being said, I think if people, I think the emotional benefits of giving might certainly disappear to the extent that people feel like they're harming others. I didn't have a chance to cover this here, but we, in our work, a lot, I was a grad student at UBC and a lot of it was done there in the early days. My work with Elizabeth Dunn there and others has found that there are key contexts that kind of increase the emotional rewards of giving and dampen it. One being this perceived positive impact, or this feeling like you've had a positive impact on another person. And so I can imagine that if you zoom back or increase the scope and realize that your kind deed is in fact stepping on someone's toes or taking away another person's job, that may very well likely hinder the emotional rewards, or in fact even reverse this effect.
Thanks.
Okay, thanks, Lara. So a question that was posed to me that I missed earlier came back again. And another question is related. So I'll try to take these two at the same time and open it up for others as well. So the question initially to me was, what would I speculate were the main reasons why the UK and the US were wrongly ranked so highly in the 2019 Global Security Index? And can I describe any general factors in the ranking that predicted poorly? I would say that the ranking, they weren't necessarily wrongly ranked. They were ranked based on a very elaborate process of identifying more objective indicators of preparedness, which had to do with organizations and capacities and so on. And they probably were ranked correctly in the sense that they were highly prepared by those objective measures. What I think is interesting is that being highly prepared by those objective measures did not have a high predictive value for the actual response in different countries. And some of the countries that responded very well, Vietnam is a very good example, was ranked number 50 in the index. So I think that, and this is now coming into hypotheses around the work that we're doing, but I think one simple statement is that poorly performing politicians can undo much objective preparation, would be one explanation I would have. And that there are things that we might learn about legal and regulatory structures and remedies that could be put in place to potentially reduce the impact of politicians on these functions, and also the role that citizens might have in accountability and so on in doing that. So the related question for others as well, do any of the international studies focus on the influence of the political situation, that are focusing on the influence of the political situation, also consider curbs to irresponsibility or frank abuse, like an effective judiciary or accountability mechanisms through free press or citizen initiatives, and what those could accomplish? So I think those would certainly be in the areas of hypotheses that we would consider in our work, but maybe I'll open that up to any of the other presenters if they'd like to comment on that.
Right.
Yeah.
Come right in.
Yeah.
Okay. We're just wondering if you're looking at factors such as Gini coefficients, perhaps as a proxy, a suggested proxy, because in terms of interpreting some of the findings of the global survey we've initiated some analysis that's trying to see any associations with Gini coefficients.
Yeah, yeah, and in fact, our preliminary analysis are showing that the more disparity there is in the country, the less healthcare workers are taken care of well, which makes good sense actually politically. So that kind of relates to the question that you were asking.
Yeah. Anyone else want to come in on that one?
Yeah, I was going to come in on that very briefly and just say, I think there are a couple of things. One is that if we look at race-based analysis, we can see that particular populations in the US and the UK are disproportionately affected. That also relates to healthcare workers, where we've seen that BAME healthcare workers have died at a disproportional rate, especially compared to the general population. And I guess the other thing that I would say is if you dive below the national, you can see quite strong differentiations, right? So Scotland versus England, Washington State versus New York State, right? Because we see that Washington State, they followed the CDC playbook as far as they were allowed to by the Trump administration. And when they did that, they had a much more effective outcome than, say, New York State. So I think there's actually much more differentiation when we dive down a little bit. And maybe the final thing I'll say, as someone who's been participating in a long-running sort of international group thinking about rankings, is, rankings measure only a tiny subset of things. And so one thing that we have to consider is, what did this ranking not go into? There were many factors that it didn't consider a lot of the sort of softer stuff, right? If you want stuff that you can rank, you look for things you can put into numbers, and that can often be tremendously misleading. And maybe just very briefly, there was a question for me about the universal versus the cultural specific. So one of the things we're arguing is that these are principles that need to be applied contextually, right? So who your civil society is very different in Senegal, where it's much more politics and religion are much more intertwined than say in a place like South Korea, where actually one of the major outbreaks has come from the secrecy of some religious leaders. But I do really want to push back against the idea that there's some sort of innate cultural reason why you have greater obedience towards healthcare measures. South Korea was a place where a couple of years ago, people were on the street every weekend demonstrating against their president, who was then removed. And now this current president has really quite high approval ratings. What we see in terms of compliance in South Korea is as much a product of how badly they performed during MERS as it is anything else. So I think we have to be extremely wary of any sort of attribution to broad sort of vague cultural attributes. I think there are much more institutional and historical explanations than that.
Okay, thanks, Heidi. That's a great note for us to end on. I agree that we'll have to have another symposium on cultural versus social and political factors determining social responses. So I want to thank our presenters. It's been a really stimulating session. Everybody was super good about keeping to time, and we really got a sense of the breadth of questions and issues that our community is addressing with more of a global perspective on COVID-19. And on that note, I'm going to turn the chair over to Tanya Bubala. I hope she's there, Tanya, for the synthesis session, and a good chance to also think about synthesis both locally and globally. So thank you. Tanya, are you there?
I am here. Thanks, Peter.
Great.
I'm just wondering whether people maybe need like a minute or two for a stretch and a break before we move into the next session. Should we start at 5 after and just let people have a health break for a minute?
It has been a long day. Very good.
That was an amazing session, Peter. Holy mackerel. I think you have another symposium all planned now.
Oh, yeah, that last question, yes, that is a very, very often raised question.
Yep.
Yeah. Great. That was a great session. Good. Wow, what a rich 2 days.
I reckon.
Maybe your work cut out for you now.
I do. I need to change something on one of the slides. Hang on. I have the wrong platform picture.
I'm going to send you one message, one suggestion I have for next steps.
Oh yeah. What did you want me to put in there?
No, not put in there. Just
just to say
put the idea about, let's see how the discussion goes.
Okay. Yeah. We have Chinetta. Janetta's on the line. I'm hoping.
Hi, can you hear me? Uh-oh. Hello?
Hello, Janetta. How are you?
Okay, good. I feel like my computer's slowing down a little bit. Are you able to hear me?
Yep, absolutely. So I sent you the slides on. I'll bring you in for the discussion. I'm just going to run through these.
Yeah, I'm going to keep my camera off until I'm called to the stage, so to speak.
All right, I guess I better do a screen share. My desktop looks like my brain. 5 million things open all at once. There we go. All right, we're at 3:05. I'm sure that people will trickle back in as I start. So I'm just going to do a very quick wrap up, and then I'm going to leave some time for some wrap up discussion, particularly on input for some important initiatives in the province, and also for a gap analysis and next steps. So first of all, I'd like to thank our supporters and the funders in this province who have enabled a lot of the research that we've been seeing today. In particular, a lot of the research has been funded by the Michael Smith Foundation for Health Research. And we mustn't forget also Genome BC, which funded a few of the studies that were presented in this symposium, but of course has a much larger portfolio of research in other research domains for COVID-19. But I couldn't have put this together without the assistance of the Academic Health Sciences Network, the other participating universities from across the province, and of course the BC Support Unit. So this is a very, very busy slide, and if I did the roll call, it will be available as part of the larger set of slides. But there are so many people that made this possible. But I want to just do a little bit of a shout out. Kat Salvante. Kat, can you just show yourself? I don't want to put you on the spot, but I'd really like you to show yourself for everyone to give you a hand clap and a thumbs up and whatever other emoji you want to send her way. Because without Kat, this work would not have happened. She is the backbone of this symposium. Of course, with a lot of help from the SFU IT team, who has been looking after us for the last couple of days, comms people from all of the participating organizations, an amazing steering committee that is representative of many institutions, and in particular, our patient partners on our steering committee. So thank you, thank you, thank you. And then thank you to all the participants. It's been lots of activity in the chat, lots of creative juices flowing, I think. And my presentation today is based on the work of the rapporteurs who are acknowledged on this slide, who sent me their notes from the breakout sessions. So I'd just like to remind you that of the representation that we had at this symposium. And when we considered who to put into the main sessions, it really was, there was an attempt made to be representative of research from across the province, from across the sectors in the province and across the regions of the province. We had over 800 people register for this conference. I think they came in and out. We had up to about 350 at any one time. We had over 110 speakers. So it just goes to show that the strength of this community and the interest in this community. And I just would like to thank everyone for their participation over the last couple of days at this extremely busy time of year, like right before school starts, right before university starts. Some people were still on vacation. Unfortunately, it's never a good time, but you know, I think we did something. It's a starting point. So I stole David Patrick's slide from yesterday because actually stick figures are harder to draw than it looks. And I was making an attempt to draw my own stick figures, and then I realized that it was just going to be easier to ask David for his. So we started in kind of a little bit of a space of reality checking in the epidemiology of the pandemic that we are under. And we looked at bubbles and transmission risks from the perspective of the size of your network. And we took that as the larger the size of your network, it's a negative impact for the COVID pandemic. But for us, that's not the case. If we take a network and think about it as a transmission of knowledge, the larger the size of our network, the stronger our networks, the more we lift the knowledge boat for all involved. It's important for us in the face of this pandemic to be collaborative and not competitive. And I think we really saw that come through in this symposium, that people are willing to collaborate, they're willing to share, they're willing to work together to make research happen. It's interdisciplinary, it's multi-sectoral. We have strong patient and community partnerships, and together we can have a collective networked impact. So the questions that we covered were sort of your aims of the research that people were doing. We structured it this way because a lot of the research has just been funded. A lot of the research is preliminary. So a lot of it is about what we're planning on doing. There were quite a few people, which was great, that could present some results or preliminary results, but we didn't want to put people on the spot. So it really was about what we're aiming to do, who we want to work with, what the methods that we're going to apply, what are the challenges and how can we help, and how might collaborations and partnerships overcome some of those challenges. Interdisciplinary, just incredible. I'm sure that I've missed things off this list, and you can throw them all at me in the chat. This was, you know, me on very little sleep, so apologies if I've missed anybody's disciplines. But we had everybody from the social sciences, from the humanities, from the clinical domains. I didn't list all of the specialties, but everything from trauma surgery to respiratory medicine, family medicine, dentistry showed up today, which was fantastic. Psychology, reminding us that small acts of kindness matters. I think that was such a lovely talk to end the symposium on. Through to, you know, the health and the data sciences that are focused on epidemiology, mathematics, statistics, all of our modeling and our data for evidence-informed policymaking or decision-making. And we brought all of this to bear on developing and implementing public health measures, evaluating and understanding the impacts of those public health measures, including intended and unintended consequences. So around that, within the main sessions and then in the different breakout rooms, we really saw the diversity of settings for this research. You know, we went from local to this afternoon to global. I couldn't believe the diversity of the settings. You know, I was trying to put together some images. I never thought that I'd be putting an orchestra into my research settings from this symposium. But that was from today. We have a music scholar. We're working across the province with Indigenous communities, in rural settings, in urban settings, in clinical settings, in hospital and acute care settings, in family practice settings, in that blurred line now between work and home, in long-term care facilities, in schools, in post-secondary educations. The list is endless. And the populations are as diverse as the settings that they work, live, and play in. We transcend the human lifespan from babies through elementary school education, through post-secondary education, all the way through to the end of days or to the last phases of life. We work with patients. We work with healthcare workers. We work with priority populations, and this is a very important message about language. And I'm respectful of not putting up images when we're talking about priority populations. So representing priority populations, I've tried to do this here on this slide, just through some of the research centers that we have in the province that work with those priority populations. So we've heard about the importance and the significance and the differential impacts of women, on different genders, on First Nations, on different patient communities, whether they're COVID patient communities or they're other patient communities, and their families and their caregivers, because of course SPORE has a very broad definition of patient. And those patients and their families and their caregivers are impacted mainly maybe because their services are impacted by a shift in focus on the pandemic. We're looking at mental health and substance use. We're looking at long-term care facilities, which was a real theme that came out. And of course, also looking at refugee and immigrant health. Shira Goldenberg was speaking in the session yesterday. Methods. The methods are as varied as the populations that we're working with. We went from everything from some really quite interventional studies in the clinical care context, through to some experimental designs that are interventional, through quantitative research that informs our epidemiology, secondary data use with health services, large-scale surveys that translate into quantitative data about all kinds of different indicators, including mental health and wellness. Exercise was a very important one for the surveys, and our changes in our physical mobility from being stuck in front of Zoom for 14 hours a day. Sorry, we didn't help with your screen time this week. Qualitative data, interviews, focus groups, policy Delphi, ranged across the spectrum, mixed methods approaches, where we're part quantitative, part qualitative analyses for literature, scoping, systematic reviews, the data synthesis piece of trying to pull all of that information being generated around the world together to assist decision making and research design. Today we had talks on BC geographies around GIS and mapping and turning that into mechanisms or modes for knowledge translation. Policy analysis, critical analysis, looking at the crucial aspects of gender and race as two indicators, for example, in critical analysis. A lot of the methods are strongly grounded in participatory and community-based research. Just some exemplar studies of the best practices available for community-based research that we saw across the past few days, including in one of the opening sessions by my close friend and colleague, Cindy Jardine, who's an expert in community-based research. Arts and music, and of course, knowledge translation. But what we heard was that, particularly in the realm of maybe some of the more quantitative areas where we're doing data pulls, or we're working with specific populations, or we're surveying specific populations, there's an opportunity for greater coordination, and that we really need to think about ways, and this is the start of the conversation here, of how we can come together as a community and coordinate in the same kind of structured way that the clinical community has been able to come together for the COVID-19, around the COVID-19 cohort. The other piece that stood out for me is the extent to which the sort of best practices around the full sort of methodological domain around what we conceptualize as a learning health system. That most of many of the projects are sort of self-regulating. They have evaluation built into the research design. They have knowledge translation that includes courses and training material built into the research design, and that because of the multi-sectoral nature of the research that we've heard about, that many of the researchers are actually in the position to implement the interventions that they're examining. And so we really need to empower those researchers to be able to move knowledge into action. and then to evaluate it and to continue that learning health system cycle. One of the highlights for me was the strength that we have in this province for Indigenous research, and how I think that the research community around Indigenous health in this province exemplifies the concept of nothing about us without us. Not only is much of the research led with or by Indigenous communities, but they're led by Indigenous researchers. And that has been a real strengthening, I think, in British Columbia over the last little while. So we have Indigenous research led with Indigenous communities, led by Indigenous researchers. And that is the only way that we're going to move from a deficit or colonial lens on research, as we were reminded in the session yesterday by Angela, to a sort of a strength and resilience focus on on Indigenous health research. And then, of course, Jeff presented on the incredible work that he will be doing, bringing the national lead of the COVID-19, Indigenous COVID-19 serology study that is community-led and empowered and overseen by an Indigenous advisory circle here to this province. So that's all the great stuff. Then there's the usual challenges. So, where are the challenges? Well, the challenges are still around data and data access, the timeliness of accessing the data, being able to access the data in the first place, the availability of the data. There's issues around being able to generate data with some populations who maybe are not as comfortable in a virtual or an online research environment. And so the accessing those populations may actually be difficult, and generating survey data or interview data with individuals who are not comfortable in an online environment, or who have challenges with language and with technology and with broadband and with internet connectivity, that all can translate into difficulty of access to generate data to work with populations. That leads to some recruitment challenges that a lot of people were bringing up. The timelines and the timeliness in terms of recruitment and data points. The coordination issue I've already talked about, and I'd like to make sure that we talk about that a little bit more, and that we have an ongoing discussions around coordination. The sense that a lot of the funding has been very rapid. It's rapid response, rapid timelines, rapid putting in those grant applications, but at the same time, the grants are for really short time periods. So there's a real pressure on. It's a pressure cooker environment. When I'm thinking that, maybe it doesn't need to be such a pressure cooker, because unfortunately, from all of the epi data that we're looking at, COVID-19 is going to be with us for some time, and its impacts, this is an inflection point in our lives. I don't think that there's a now we're doing COVID research, and at some point, we're going to be doing something else. This will always be in our lifetimes an inflection point in any health data that or projects that we're doing. The funding is a concern. There's an amazing amount of research. You might wonder why I've got a desk here. It's the corner of your desk. There are so many people doing amazing work off the side of their desks in their spare time, giving back to the community out of the goodness of their heart, who have not been able to access research funding. And I don't know that energy can be sustained over the long term without some commitment to resourcing the really important and significant research that we've seen over the last couple of days. So, some enablers we learned about today. That was a fantastic session this morning, where I'm hoping that the researchers that were present were able to have some reassurance that there are some entities that have their back, that are there to support, that are there to provide help. So, Pop Data BC came and gave a great talk this morning. All of the things that come along with the BC Academic Health Sciences Network, through harmonized ethics, through the BC Support Unit for connections with patients and patient engagement, Clinical Trials BC, the COVID-19 research inventory, where you can look and scan and see all of those other people that are working on related issues that you can work with, and of course supports through BC Support Unit and others for KT services. And then of course there was a lot of interest in Reach BC in terms of not just for clinical research, but even for survey research and other forms of research, connecting with people that are interested in participating in research. So I'm hoping that the last couple of days are a start to conversations, and that these will continue, that you've met some people in your communities. Yesterday, for example, Travis Solway in my own faculty was chairing a session that included researchers on mental health and substance use, and they're already talking about, yeah, we all need to come together and we need to start to continue this conversation. We need to have another, half day or a one-day symposium just around specific subtopics. So I think we went broad, but I think there's a lot of room to take some of those communities from that breadth and engage in greater depth. And I hope that the way that the smoothness, I think, of the way that this ran, it was not a huge burden financially in particular. It was a burden in terms of time, but not necessarily in terms of cost. And so I'm hoping that this can be an exemplar that communities can actually come together to continue conversations. And then finally, I'm going to have Chinetta Jones from who's a VP Research from Michael Smith join me. And I'm hoping that Kelly is still on the line as well, Kelly Bernard, to reflect on some discussion questions, to assist in the development of the next round of the strategic research priorities for the province, give some feedback to our funders, including Michael Smith, reflect on gaps that might have been identified over the last couple of days. Reflect, and Chinetta is particularly interested in this, on the way that we can evaluate the impact of the research that is being done on COVID-19, and then just reflections on next steps and outcomes for the symposium. So with that, I will thank you, and I will close off the slides, and I will turn it back over to Peter to continue chairing, I think. Do you want me to?
I think you should go ahead, Tanya. Go ahead.
Okay, all right. So thank you for bearing with me there. So Chinetta, would you like to say a few words about Michael Smith's interest in the evaluation piece?
Yes, thank you, Tanya. Can you hear me all right? Okay. So no, excellent summary, and it was great. And actually it really allowed me to reflect really how much, COVID-19 and what we're facing really was underscored by the importance of coordination and collaboration. And that's among, health researchers and decision makers and healthcare professionals. Really nicely acknowledged by Dr. Bonnie Henry and Dr. Joy Johnson, and showed up really strongly in the presentation and in the discussions over the last couple of days. So as Tanya mentioned, we at the Michael Smith are very interested in understanding and reflecting really in the last few months in terms of what's worked and where could we have, we collectively as a province can work together better going forward. These are preliminary discussions that we're having with the Ministry of Health, led by Victoria Shuckle, the Strategic Research Advisory Committee with David Patrick and Kelly Barnard, who you heard from yesterday, and with Sterling Bryan, excuse me, leading the Academic Health Science Network. Really, we're interested in evaluating the provincial research response to COVID-19 in BC. And the purpose of this is to really derive whatever insights and lessons that we can take away to strengthen coordination and collaboration across the province. We would love to take a strengths-based approach because we've heard some amazing things that have happened and worked quite well, but we also recognize that there have been challenges, so we'd like to hear about both. This is very much focused on, at least in the initial stages, on the research response, not on the public health response. And very much focused on this provincial coordination and collaboration. So, it's too early to really track research outputs. There'll be an appropriate time to do that much later. Our starting position then is that the efficient and effective coordination and collaboration is important for the provincial research response to COVID to achieve what we've heard is collective impact and primarily for the benefit of the patients and the public. And we can't really lose sight of that. What we're really interested in hearing about are what are the conditions and the mechanisms in place that really draw and build on BC's strengths, including kind of people, infrastructure, and institutions. What's worked well, as I've said, and what do we need to put in place to really effectively support that? I'm just going to highlight a couple of questions. These are not by any means really decided, but just to give you a sense of the kinds of things that we're interested in, and certainly welcome in the discussion now any thoughts in the chat box. So please do send us your initial thoughts. The kinds of questions that we're thinking about are, what are the mechanisms that are in place for connecting researchers and decision makers or practitioners, and how effective are these? Another question, what mechanisms and conditions are in place to effectively engage the patients and the public? To what extent is provincial infrastructure in place to support a coordinated research response? What's missing or needed? And I know that Kelly has also been thinking about this and received some excellent feedback. What mechanisms are in place and to what extent do they support the coordination of research and collaborative working? So these are just tasters, but certainly would welcome any thoughts from all of you who are tuning in now, and also to our mailbox srac@msfhr.org in terms of any questions that you think are really important questions to ask as we take this time to reflect and think about what we need to understand in order to be able to work more effectively going forward.
Peter, I think you have some thoughts.
Okay, thanks, Tanya. Yeah. So this has been a great experience for me. For those of you who don't know me, I'm relatively new to British Columbia, completed about 20 months. So this was a great opportunity just to meet virtually many, many people that I'd heard about, and even many I hadn't heard about, and get a great overview of the work in public health, population health research, health systems research, and so on. I guess I wanted to share a couple of thoughts following up on Chanetia's comments about kind of things we should think about going forward. I was a bit struck by the what I think is the situation in BC today is one in which the clinical impacts of COVID-19 probably are, for the moment at least, less dramatic on the population as a whole as the non-clinical impacts. But I was struck by some of the difficulties we encountered, for example, in digging deep and being sufficiently representative or having sufficiently substantial results, for example, about the impacts on different subpopulations. I think, for example, the question was raised earlier about whether we are adequately representing or sampling by ethnic groups or economic groups and so on. We do pull out of large surveys those covariates, but that's not the same as having representative samples. And of course, different subpopulations are distributed very differently geographically around the province. So that's one area. And the second area that I really think we could dig deeper is in this broad area of other consequences. I'm not crazy about the term unintended consequences, because in fact, some of these consequences were very much known and expected as a result of a strategy that really emphasized, bending the epidemic curve and reducing the number of cases and the severity of cases. So there was a policy trade-off envisaged that there would be impacts on the population from doing this, but I do think that there's much more to be done now on really understanding those impacts and the impact of compensatory policies, economic and social policies, and so on. And this is another area where our community really could could work, I think, more coherently. So then the question is, what about the structures? Janetia mentioned, well, what about the structures that are there? And I think that's really something we're thinking about quite a bit. Our research enterprise is very much driven by individual initiative, responding individually to funding opportunities, and producing results that get published in academic journals, for which researchers get professionally rewarded. That's great, but that doesn't automatically translate into more generalizable synthesis and conclusions. That's kind of left to some black box. And I think we could pay some attention to that a little bit better, both in terms of the funding strategies and also the part that happens after the research is done, this sort of synthesis part, the knowledge translation part. So just some thoughts from my side. I don't want to be, the sort of the negative voice. This was a wonderful event, and I am greatly appreciative of what everyone has done. But this is a time to learn and think about going forward as well. So we'll put those ideas out there. Thanks.
Thanks, Peter. I'm seeing a few other gaps that are coming through in the chat, and I'm seeing Sterling. I'm seeing I think some suggestions that will be directed towards you for having I'm assuming one way to do this would be another event, something like this, but that is much more patient focused, and that would have equal time. This one was very much about, how do we get our methods together? But I think that it behoves us to also think about how do we work better with our patient partners. The call was open. We did not reject a single talk that came in, but we received only 2 from patient partners that were speaking in the breakout rooms. So I think we should think about another event that would be more inclusive of community participants, that I think would be pitched somewhat differently. So I'm not sure, Sterling, we have some event organizers, things like Public Square and Center for Dialogue, that are much more directed around being able to host a much larger community discussion as opposed to researchers navel gazing. So Sterling, would you like to comment at all?
Sure, thanks. I think the comment is that we didn't see patients presenting at this meeting, and I think it's important to recognize that we engage patients very early on in the planning process. So we have had patient and community engagement in the planning of this conference, and I think if I was to if we could be Doctor Who and we could go back in time, we might now do things a little differently, of course, but we can't do that. So I think you're right. I think what we need to do is think. We've made great progress in BC and in Canada and actually internationally in this space of patient-oriented and public-oriented research, and there's no going back. Like we're not gonna backslide on that. Period. Like it's a culture change that's happened, and it's for the better. And I'm embracing it fully, and I know that many colleagues in BC, research colleagues in BC are. So I think we just need to recognize that. And I do think I like the idea now of actually having a patient and public focused event, but with researchers as well and with policy. I think it's about the stakeholders coming together, but actually listening effectively to the voices of those with lived experience. It's absolutely what we should be doing. And yeah, just to say again, there's no sliding back on that. I'm not going to let that happen, and I think everyone else here is committed to not letting that happen as well. But we need to learn, and we need to recognize that there are areas that we could strengthen.
Yeah, I think that's a really good summary, Sterling. I think we can move forward to a partner event, and would be happy to help. I also think that now we're at a point where we have an identified COVID-19 patient cohort people with lived experience of various severities of COVID-19 who have been consented as research partners and patient partners in research. And so I think when we were planning this, that was just, we hadn't even gotten to that point yet. And so certainly we now have a population that we can reach out to. The other question that we have in here, which I think is very important, that I think that one of the things that really came through in this event is our issues around long-term care, our seniors, about advanced care planning, about all of those issues that are related to the age of our population and our care for our elders. So I think trying to plan something around that, I think would also be, I'm going to put words into your mouth, Victoria, but I would not be surprised if that would be something of significant interest to the ministry. So I think Kelly's heard that as a strategic research priority loud and clear. Kelly, did you want to comment on some of the priorities that you were, before I turn it over to Victoria, would you like to comment on some of the priorities that you've been hearing?
There we go. Yes, thank you so much, Tanya. This has been an amazing couple of days. What a wealth of information and knowledge and expertise, and people's willingness to come forward and discuss and talk about collaboration is amazing. I think we've had a really great chance to shine a light on the research environment in BC. And what we're seeing is pretty good, but it's also shining a light on some issues that may have arisen for researchers. And we're very interested in making sure that we're supporting people to do the best they can with the timelines and the constraints, but also the opportunities that are arising as a result of the funding and the approach that people have taken to this problem. We are seeing unprecedented levels of cooperation amongst researchers and a real willingness to bring together information and resources and share methodologies and so on in a way we really hope for. And I would hope that that's a continued legacy of the work that people are so tirelessly undertaking right now. So I would really love to hear from people about how they feel in the research environment in BC and how indeed have we made the best of our assets, have we? Are there remaining gaps or impediments that people are facing as they try and approach their research? And are there opportunities to think about research in a different way as we go forward, and thinking about opportunities for different approaches to collaboration within teams, cross-disciplinary, cross-institutional, and how can we do that meaningfully as we move forward? So I would really love to hear from any of you with respect to your ideas about how we take a strategy such as this forward, and how we learn from shining a light with this particular focused issue on the longer term needs and capabilities of our research system. So please feel free to contact me. I've sent the email link is there, the srac@msfhr.org, and correspond with us at any time about these things. We're vitally interested in your experience and your input into this.
Thanks, Kelly. Victoria, did you want to say a few words?
You know, the only thing that I wanted to say, thanks, Tanya, I wasn't expecting to say anything, and I won't. I think that what you have said and what Kelly said was great. The one piece that I would just comment on, I'm just so thrilled to have listened to a number of the different studies and to hear how far along, even if it's not, the study's not complete, just how much information is being generated and is in people's hands right now. And I hope, I sent you a note earlier, I hope that we can talk to the symposium participants and ask for their support in providing some of the linkages. Maybe, I don't know if it works to actually do it directly in the inventory, but if there's some way that we can capture the links that in some cases people were providing in the chats, in other cases in their slides, if that can actually be centrally pulled together, that would be, but I just feel like it's been a really rich 2 days and very, very appreciative.
Thanks, Victoria. I'm hoping that the participants from the various government ministries feel enabled to connect with any researcher that they feel is doing work that is relevant to questions of specific significance or things that they're working on or stuff that they would like help with. I'm hoping that there's been a little bit of behind the scenes matchmaking going on between significant research questions and researchers that are working on them in the province. So I think I'm not seeing a lot more. I think that everyone's brains are probably fried. I know that mine is. It's been an amazing couple of days. I do undertake to pull together a bit of a summary with the steering committee for the workshop. I'm hoping that we can find a way to connect people that want to be connected. We do have everybody's emails. We don't necessarily have consent to share them all, but I think we can share at least the main speakers. They shouldn't be too hard to find. But if other participants want to specifically connect with individuals that they can't find an email address for, do reach out for us and we can ask for permission to put you into touch. We will also undertake to go through the chats. We've been saving them to pull all of the resources together and put together a resource page that we can give to Academic Health Sciences Network to post with the main sessions when they become available on their YouTube channel. I think that will be helpful. Yeah, Sterling. Yeah. And if you missed anything and you want to go back and look at anything, the main sessions were recorded and they will be posted. And so with that, Bev, is Bev on the line? I just wanted to thank Bev and Michael Smith so much. Janetta's here, but we're so lucky to have such an active and supportive funder in this province. Not every province has one. And certainly the resources that are distributed through the Michael Smith Foundation for Health Research enables a lot of the fantastic work that we've seen over the last couple of days. So thank you, everybody. Yes.
Can I just, so we do have Putting Patients First, which is our virtual conference happening on October the 8th for the BC Support Unit. It's not focused on COVID exclusively, obviously, but I think it is a place where conversations could continue. So and all stakeholders would be welcome and be participating in that event. So yeah, I just wanted to remind people of Putting Patients First.
Thank you so much, Sterling. That we'll circulate the link to that as well. All right, thank you. Goodbye, everybody.
Thanks, Tanya.
For those of you who are in the post-secondary sector or sending your kids to school, good luck with the start of the school year for big and small, and we will see you later.
Congrats.